Bom dia a todos. É com grande prazer que nós começaremos em 2 minutos o nosso 11º Workshop Internacional, Testes Diagnósticos de Qualidade Assegurada e Acessíveis para Programas de Saúde Pública. Assim como nós fizemos ontem, as discussões foram extremamente ricas por trazer essa experiência dos diversos países, das diversas situações em que o diagnóstico é uma das melhores, se não a melhor ferramenta para garantir o acesso a terapias cada vez mais eficazes. Diagnóstico precoce e preciso, de fato, leva às terapias adequadas. E é dentro desse mantra em que o teste certo, para a pessoa certa, no lugar certo, no momento certo, como José Alonso ontem encerrou a sua apresentação, e é o mantra que todos nós no diagnóstico seguimos, nós hoje vamos discutir diversos exemplos de programas de saúde pública, tanto no nível federal, quanto estadual ou municipal, e que tiveram grande sucesso. Essas experiências são ricas e merecem ser compartilhadas. Não só experiências passadas, mas projetos futuros. Convido a todos a que se manifestem durante o evento. Teremos aí possibilidade de responder às perguntas, muitas pessoalmente e outras através do Q&A. Logo abaixo vocês têm o espaço para interpretação, onde vocês podem escolher o idioma mais adequado, inglês, português ou espanhol. E logo na sequência teremos então as primeiras apresentações. Com a câmera? Bom, de qualquer jeito, hoje então nós começaremos mostrando
So we will start by showing you another video, which is another moment of simulation. Yesterday we showed a video with the COVID simulation, and today we have an example for the dengue simulation, the use of rapid dengue tests in moments of a public health crisis as a great tool. This video creates opportunity to have a discussion with different stakeholders that will simulate real life, putting themselves in other people's shoes, as we often say. And the idea here is to understand what are the difficulties that a regulator, public manager, and all different stakeholders face during this journey. So let's watch the video just to give you an idea.
It's estimated of about 100 million cases of such infections occur a year where people develop this acute illness. Underneath this is perhaps another, somewhere between 200 to 300 million cases where people are infected but not manifest any symptoms and therefore do not know about it. But collectively, this 400 million people then allow the virus to then keep perpetuating itself and be transmitted again and again across the world. And so this is what's causing the burden, this sheer number of cases.
So dengue in the Philippines is actually what we call a hyper-endemic disease. That means it just pretty much happens the whole year round. There are some peaks during the rainy season, but we have about 185,000 cases per year. And about just under 1,000 deaths.
During outbreaks, it can overwhelm healthcare systems because so many children or young adults or teenagers or adolescents need to be hospitalized.
There are major epidemics in many countries on an annual basis. Dengue is a major public health and economic problem globally. And the pandemic that's been going on for over 40 years has been driven by global trends, primarily urban growth and globalization.
So not only an increase in numbers, but we've also seen a geographic expansion that now includes a wider span of countries that now report on dengue, including southern areas of Europe, northern parts of Australia, and other southern parts of the US. So this disease needs to be addressed because it is related to globalization and urbanization and climate change. And all these three factors will only exacerbate dengue, and we need to address it.
So this problem is not going to go away. It underscores the desperate need for new tools to prevent transmission of the disease, prevent these epidemics from occurring.
And we need to be able to couple that with a way of increasing population immunity. And the best way of doing that is a vaccine. The first one, of course, is by Sanofi Pasteur, where they used the yellow fever vaccine, which is arguably one of the best vaccines in the world. And yellow fever is related to dengue. And so use that vaccine strain as a backbone, and then just engineered in the shell of dengue virus, the structural genes. So that's the one that's been licensed in most countries, including FDA. Unfortunately, it turned out that from clinical trials that this vaccine doesn't work very well if you've never had dengue before. It works very well if you've had at least one episode of dengue. And so not only does it not work well, then it appears that there may be a risk of that if you vaccinate someone who has never had dengue before, and then when they do get dengue after vaccination, that the chance of getting severe dengue is higher than if they've not been vaccinated.
However, when Sanofi announced the problem with the vaccine, where they actually saw that there was a potential for harm among those who had not yet had dengue, this was actually this caused mass hysteria, and so there were some people who were pretty much poorly communicating the risk.
One of the problems that maybe perhaps a lesson learned from what happened in the Philippines is that the surveillance need to be put in place before the actual vaccine rollout. Otherwise, anything and everything can be easily attributed to vaccination, and that completely derails disease prevention program.
I think a rapid, inexpensive test to determine past exposure to dengue is really essential, especially in the Philippines, to getting people to accept the vaccine again.
I think the key here is trying to get politics out of public health decisions, number one, and number two, better education of the public, education of the physicians, the medical community, education of the policymakers and regulators.
Bom, esse é exemplo de material que é compartilhado antes.
This is an example of a material that is shared before the exercise that then is carried on to try to improve the learning curve among all different stakeholders that are part of this diagnosis effort. Now I'd like to invite Ms. Rosana Pillings for her initial remarks and talk a little bit about the role-playing exercises that we have been doing through the simulations. Rosana, the floor is yours.
Thank you, Carlos, and welcome to the second day of the workshop. I think that yesterday we had really fruitful discussions, and I look forward to more of that today so that we could explore options on how to move forward. Now, with regard to this simulation exercise for dengue, I think what we like to do is explore, as you saw on the video, the need for a test to do the pre-screening so that we know who is positive who had been exposed to dengue to know who's eligible to receive a vaccine. And so in the scenario that we set up, we have a parent who has died, who has a child who died of dengue. And can you hear me?
Yes, we can hear you.
Yeah. And then we feature him talking to his neighbor about the fact that he heard about a vaccine from the news and from social media, and that he said to his neighbor that he should get his children vaccinated, because if he had known that there was a vaccine, maybe his child would still be alive today. And so this is how it would go. And and then when the neighbor takes his children to the doctor would say, well, yes, there's a vaccine, but it's not so simple. Because I think that if the person is not exposed, then to dengue first, then there is a risk that maybe the person who's vaccinated, who's never been exposed to dengue, would be more likely to be hospitalized. But it's a small chance, but it could happen. And now the neighbor is not so convinced, and he said to the doctor, is that test reliable? Should I get it, or what's the, really what's the risk? Because epidemiologically, we may say that it's a small risk, but to a parent, it could be a very big risk. And so then we move to a scenario where the regulators and the policymakers are trying to determine what is the sensitivity and specificity of that test, because there's no consensus so far as to what it is, because the performance of the test really depends on whether you're in a dengue endemic area or a low prevalence area. That performance could be different. And so in the final scenario, they try to listen to a medical expert to explain about that, and to explain what is the best way to not only have the test so that most of the population can benefit from the vaccine, but also that what are the ways that they could mitigate the risk. So those are the sort of scenarios to play out to show that the test is required, but the performance is not uniform across the world. So there's no consensus on what to do right now. And that's a difficulty. So back to you, Carlos.
Thanks a lot, Rosana. Então, dessa forma, vocês podem ver que nós temos...
So you were able to see that we are able to support universities and local community groups in different regions in Latin America, providing support through materials and supporting local initiatives like Leon mentioned was done in Peru, and colleagues from Aladiv do in other countries. The idea is to promote the value of diagnosis through different discussions so people can truly notice how important an accurate and timely diagnosis is for the correct individual in the right setting. Having said that, we are going to move to the first roundtable this morning, and we're going to talk about the user experience for HIV self-testing, the possibility for incorporating other types of self-test. Segundo Leon, who is a member of the board of Aladiv and a professor from the San Juan Bautista University in Peru, will be moderating this session. Good morning and welcome to the second day and the second part of such an intense day. As mentioned by Carlos, we continue to talk about tests, and we will talk about self-test for HIV and the experience of Brazil, because definitely what was done about HIV in Brazil and in other countries to incorporate other self-tests can be useful. We have a very interesting discussion with Mariana Milhares from the Ministry of Health, Alison from the Ministry of Health of Brazil, Ana Paula Moreira, Carlos Solidan from the University of São Paulo, Mariana Vilares. Good morning and welcome.
Good morning, everyone. Can you hear me well? Okay, perfect. So good morning, everyone. It's a pleasure to be here. I have watched the talks yesterday, and I think some of the information I'm going to present is going to contribute. My name is Mariana Vilares. I work at the Ministry of Health at the HIV diagnostics and hepatitis and other STDs department. So today I'm going to present how the self-testing of HIV is working in Brazil.
E agora vocês conseguem ver no modo já de apresentação?
Please confirm if you can see my presentation in the presentation mode. Okay, perfect, thank you. So José talked a little bit about this yesterday. So just to give you a little bit of context, this is our cascade. So we are focusing on the improvement of our status. So we have 88% of people diagnosed in 2020, and this increase is due to the rapid test that was implemented in 2012, and therefore there was this acceleration. The closer we are to 90, 95, and 100%, the more difficult it is to actually get to those people who are missing. So what is our challenge? To reach that population that was not reached yet. So José has presented this yesterday, but this is the data of prevalence in Brazil. So in the general population, we see 0.4%, but in gays and men who have sex with other men, 18%, women sex workers, 5%, and trans women, 16.9%. We also have a very young population that needs to be in focus. Since this is a concentrated epidemic, we need focus, and the most vulnerable population that have less access to healthcare services are those people that need to be reached. Therefore, we started to work with the HIV self-testing since 2018. Our strategy to distribute the auto tests is to reach people that are not diagnosed. The focus are key populations and prioritary populations who do not have access to healthcare services. And the main strategies are the distribution of tests outside the healthcare service and the secondary distribution through partnerships. So on the right side, it's illustration of from the black dot getting to the other secondary distributions. We have three strategies for distribution. The first one is to deliver self-tests to PrEP users so that they can deliver it to sexual partners. People using PrEP are people who understand HIV, know that they are at risk. There are criteria for people eligible for PrEP use, and they have contact with people who could benefit from this technology. So they could get at each appointment 5 tests to deliver to sexual partners. Our second strategy is to distribute tests in sociability locations, which can be done through healthcare professionals. And this strategy can deliver self-tests to people who are approached and other 5 tests to sexual partners. Another strategy is to deliver the test to people coming to healthcare services who are during an appointment or doing a test, and they can receive other 5 self-tests to deliver to other people. We have one guideline document that is available on our website. There you have the details of our strategy if you want to find out more. We have 15 minutes only, so that you can find additional information there. On our website, we have a page dedicated to HIV self-tests. So you can find the information about how it works in the public healthcare system, additional information, how to perform the self-test, how to interpret the result. You can also find where you can get a self-test for free. There is a frequent question session, also information materials, and these are some examples of what you can find on our website. So you have a brochure, you have a poster that you could place at locations for distribution. We have short demo videos. We have 2 videos. We started the strategy with one blood self-test, and now we use the oral fluid on a self-test as well. We also have a video talking about the auto test and how it works, another brochure, and the interactive panel where you can find additional information. Since 2018, we have been conducting a monitoring to help in decision-making and adjust the strategy if necessary, and also to update the public policies. How do we do that monitoring? For people living with HIV who go to an appointment, they make a registration when they get an auto test. And for people who do not have a follow-up at the public healthcare service, they fill up an anonymous form with social demographic information about sexuality. So to talk a little bit about the results, this is probably our main slide in our presentation. We started with a pilot program in 14 cities in December of 2018 with the use of blood auto test, the action test. This data is up to September 2021. So you can see that this is the number of self-tests distributed per month. So we started the pilot program in December 2018. We conducted a workshop with regional coordinations and representatives of some strategies and NGOs in July 2019. So you see an increase of number of tests distributed after the workshop. So we've expanded a little bit the population. In January 2020, we've enlarged the program for the whole country. So up from January, the whole country could distribute self-tests. In March, we had the beginning of the pandemic, so we've seen a small reduction of the number of tests distributed. And then we released a note about recommendations on social distance to talk about the importance of self-testing. We started to recommend the use of auto tests so that people could substitute the rapid tests by self-tests so that key populations could be reached. So in April, we published those recommendations and we conducted a few webinars to talk about that document and answer questions. And then in May and June, we can see a quick increase in the auto test distribution. We ended up clearing our stock, and we had already a purchase with the Ministry of Health going on. So by the end of November, our stock was depleted, but we still had some local stocks, and so the distribution did not stop. In April this year, we started distributing a new test in the public healthcare system, which is the HIV Detect that uses the anaural fluid sample. So this test was approved by Anvisa regarding its technical features, and it presented the lowest cost. So we started seeing again an increase on the distribution of the self-test. Here at the bottom, you can see the strategies. So this is the individual distribution, the distribution for PrEP users, distribution for HIV and PV to bring over to partners, the consolidated distribution, which is when we do not have individual forms, so we leave a certain amount of tests in locations where people go to, and the total of 344,209 tests distributed up to September. This is a chart showing the number of cities distributing self-tests. In blue is the number of cities distributing tests during that month. So you can see that with the decrease in stock, there's a decrease in the number of cities. In red are the new cities, and the green line shows the accumulated number of cities. So up to October, we had 239 cities in Brazil distributing the auto test. We will have data from November published on December 10th. So what are we able to reach? What is the result of our work? Here on the left-hand side, you see the mean number of auto tests. So it varies depending on the strategy, but on average, people get 3 auto tests each. Here below in the dots, you see information regarding the age of people who get auto tests. So Jose talked yesterday about the young population getting infected by HIV. So we have to reach that population. It's a type of people that do not go to the healthcare services. So 20% of people getting auto tests. This is data from people who went there to pick up tests, not necessarily the data about people who conducted tests. So 20% were between 18 and 24, and 21% between 25 and 29 years. So 41% of the people were between 18 and 29 years. Regarding the last test for HIV, 20% had never done an HIV test, which shows that we are getting to a population that we did not approach before. If we see the age between 18 and 24, this percentage goes up to 27%. So we are approaching a population that is much younger and that does not do any tests. Regarding gender identity, we see that the largest population reached with this strategy are gay men and men who have sex with other men, then cis women. And what we also believe it's interesting, it's this 5% here of trans people. We would like that number to be higher, but we already believe that 5% is already good because we are reaching those people a lot more than the traditional healthcare services. Regarding race and color, 51% is white and yellow, 48% Black people, 1% indigenous people, and 2% ignored. Regarding our interactive panel, you can find all the information from those two last slides on that website. So here's the hyperlink to find all that information there. And there you can see all the information regarding the HIV test, and you can filter the information. So here is the first page. You can filter by state, for example, and then you can get separated data by state. And without filtering, this is the information on the panel. So you see there are 4 of 7 pages there, and this is the filter regarding Brazil. But if you want to select, for example, other state, you can do that and you can check the information about that particular state. You can also select by individual distribution or through the PEP strategy, and there's a lot of information that's very interesting for you there. That would be it. Thank you so much, and I'm available for any questions later on. Thank you.
Thank you, Mariana. That was very interesting. 350,000 tests or self-tests distributed, and a high percentage of people between 18 and 24. This is really interesting. The data that you shared are really an example that many countries need to follow. We have some questions for you, Mariana, so please stay with us. Now, I would like to invite the representative from the Ministry of Health that will talk a little bit about decentralization of diagnosis. Alison, good morning and welcome. Good morning, everyone. I'm going to share my screen, and please let me know when it is working. Can you see my screen? It's perfect. Actually, we can hear you, but not see the presentation. Well, first, I would like to thank you for the invitation for coming to this event. The discussions since yesterday have been really fruitful. I have some data from Brazil, and part of this presentation is an invitation for us to think as a group in which areas we can advance in regarding diagnosis, especially in providing autonomy to users and different individuals. My name is Alison Bigelin, and I'm part of the diagnosis team for the Department of Chronic Diseases and Sexually Transmitted Diseases or Infections. We have been talking about this decentralized model. An initial model that we have is based in lab tests. And in this case, we need people to leave their homes and go to one health care center for an appointment, and later either that person or the person's sample is sent to the lab, and that person then returns home and wait for the test to be conducted, and later needs to collect the results. So there is a whole journey that this person needs to go through in the healthcare service. But if we think about more specific situations, if we look closer at some people, they can be living in high vulnerability situations, which make it impossible for them to fulfill this journey inside the healthcare system. Many times they use their financial resources for other purposes instead of for paying, for example, for transportation to go to the healthcare facility. A model that is based on rapid tests, individuals, they go to the health center and they have access to the diagnosis right there. But even in this model, we still need the support from the lab for some specific situations. But if we look at some groups of people, for example, sex workers or trans people, some of these people don't choose this model due to the stigma that is associated to them. And then we have a third model that was presented by Mariana, which is a self-test model. Individuals that test negative in this model, they already have an answer and do not need to go to a healthcare center. However, if they test positive, they do need to go to a healthcare center to conduct complementary tests with the support of a lab. So this is the possibility that we have for decentralizing diagnosis. Another way to approach this is when diagnoses are centered in the healthcare center, several different individuals will need to access the same health care center that, especially in Brazil, are overcrowded. We often hear about how crowded these services are. So this only highlights the need for decentralizing this service. When we think about a model that focuses on the autonomy of different people, only those who truly need to continue their treatment will go to these healthcare centers, and that will bring a more agility to the whole system and an ability to focus on those people who truly need to be seen in the healthcare center. We have been working on the use of rapid tests for a very long time in Brazil, and I would like to highlight some moments during this journey, especially regarding rapid tests. So in 2001, we started to see in the recommendations for the prophylaxis of the mother-child transmission of HIV, the recommendation of using rapid tests for some specific emergency situations. In 2007, in the first clinical protocol to prevent the vertical transmission of HIV and syphilis, the rapid tests were presented as an alternative for diagnosing syphilis. Later, in 2012, the Ministry of Health included rapid tests in the basic healthcare level for the detection of HIV and syphilis, which allowed us to decentralize the model. So here are some strategies that we use in Brazil. Like I said before, the rapid test in the primary care services. We also have some projects that are conducted by civil society associations that they do a screening testing strategy. And this project between 2018 and 2019 demonstrated that 1.4% of people had a positive test for HIV, and 47% of those people had never been tested before. And as mentioned by Mariana, we also have the distribution of self-tests for HIV in the country. Now, some data about the decentralization model we have. We can see that since 2012, there has been an increase in the number of tests distributed by the Ministry of Health, with a slight drop in 2019 and 2020, probably the result of the pandemic, but with a slight increase in 2021. This is data that goes up to September this year. In 2020, 2019, the Ministry of Health performed a great acquisition of rapid tests, and we can see that HIV rapid tests are already present in 95% of cities in Brazil. They are represented in the green area in the map, showing how this methodology is truly decentralizing the testing in Brazil. But as mentioned by José, it's important to consider the quality of these tests. So at the Ministry of Health, we use some tools to conduct frequent assessment of the tests. We have a tool for remote training for the use of these tests. The National Institute of Quality Assurance conducts an analysis in all the batches that are acquired by the Ministry of Health. We have an external quality assessment program for rapid tests, and we monitor any problems that can come from the use of the tests that are provided by the Ministry of Health. So as seen before, we have this cascade of continuous care, and the use of rapid tests from 2012 up until 2020, we were able to see an advancement in the diagnosis of HIV. So these tests have made a great contribution in that sense. And as previously shown, we have a higher prevalence in some population groups, And we need other strategies to reach those population groups. So the Ministry of Health published a quick guideline for focus testing, so we can truly start focusing on the population groups with a higher prevalence of the epidemic. And one of the strategies in the guideline includes the testing of sexual partners of those people living with HIV. Another strategy adopted by the Ministry of Health, later Daniela is going to talk more about this, but we are conducting validation studies, and in the next year we will incorporate rapid tests for the simultaneous detection of HIV and syphilis. So we would be able to detect two diseases in the same test. And this is another strategy to expand diagnosis for both diseases in a single test. Now, if we think about other conditions, the World Health Organization published this year a guideline with recommendations on the use of self-testing for hepatitis C. This test is being approached as an additional approach, and it is recommended by the WHO with a strong recommendation with moderate level evidence. So the guideline mentions that the hepatitis C self-testing it's a convenient option for people that do not usually go to the healthcare centers and that prefer to use self-care in their lives. And the idea is to expand access to different population groups in places with a high prevalence of the disease. The implementation, however, should be focused in priority population groups and regions. There is no direct evidence on the efficacy of the use of hepatitis C self-testing, but all the studies were based on studies regarding the efficiency of HIV self-testing, because this is an experience that exists globally. So regarding our experience with HIV self-tests, we know that it increases acceptance to be tested, it increases access. People that use self-tests receive comparable care to those using the traditional healthcare services, and social damages are very rare. So that support us in the new strategy of start using hepatitis C self-testing. Many people show that they want and they're capable of conducting the tests, is acceptable and feasible. It, again, increases access to those who couldn't be tested in any other way. And even though they are more, they allow us to diagnose more cases. So the guideline also presents all the different steps of implementation for hepatitis C self-testing. I would say that Brazil is still at the planning stage, at the first stage. We are reviewing data, identifying the gaps, and what strategy could be used to include this testing in the country. Regarding syphilis, the situation is a little bit more complex because the diagnosis of syphilis is based on the combination of tests, and we know that the non-tryptopanic tests, even though we already have some automated testing, some self-testings, they are still very much focused in the laboratory model. And since most people remain positive in their testing, how could we use a self-testing, or how strategic would be to do a self-collection in regions with a high prevalence? WHO has been working in some recommendations for self-care interventions, defining self-care as when individuals, families, and communities can prevent diseases, maintain their health with or without the support of a healthcare professional. So the idea is to decentralize the model and provide more autonomy to individuals. A study from 2015, and now I'm talking about self-sampling, another strategy to decentralize diagnosis. A 2015 study mentioned self-sampling in a quantitative analysis with the use of DBS, and it showed that this model allows for a more private sampling, more accessibility for potential users. It's easier to do the sampling and to transport the samples, and it reduces overall costs for the healthcare providers. And again, it's that idea of providing access to everyone who needs it. This study is a meta-analysis review with the use of self-sampling in comparison to the sampling conducted in healthcare services for chlamydia and gonorrhea. And it shows that sensibility and specificity for vaginal self-sampling for chlamydia and gonorrhea have a pretty satisfactory performance. So it is a strategy of using this type of vaginal self-sampling, and a high sensibility and sensitivity for urine sampling for detecting chlamydia and gonorrhea in men. So we have studies demonstrating how much self-sampling can contribute to the detection of other STDs, such as chlamydia and gonorrhea. This most recent study shows at-home self-sampling, and it basically assessed the acceptability of at-home self-sampling for SARS-CoV-2. And the study showed that more than 84% of individuals reported that collecting, packing, and shipping of saliva, OPS, and DBS specimens were acceptable, and nearly 87% reported being confident on the results that were collected at home.
Another study shows the risks of self-testing. So it's the low return rate of laboratories, the uncertain follow-up. So if people are going to services, the unnecessary use resulting in false positives, the incorrect use or lack of comprehension of the window, and lack of vigilance data. So the study brings all the models that I've mentioned before. We can have a self-testing model or a self-sampling model, and that sample is sent to the laboratory for analysis. So here are the different models. There are benefits and disadvantages of each model, but with all of them, we have a potential for reaching people who need testing and how they might be linked to the care. So maybe the rapid test is the one that creates more linkage because it's already offered during the appointment. This is an example of use of self-testing or self-sampling in the UK. So people are able to go on the website, and based on their age and location, they offer different self-testing models, and the tests are sent by mail for free, and they can do the self-sampling and send back to the laboratory. There are challenges like regarding the orientation of individuals, the validation of the assays for this type of sampling, the validation of logistics, and the return of the results, and how to guarantee that people have a follow-up. This is our last slide talking about the future. We're thinking about using drones to transport samples. Of course, this is a model being tested in Brazil right now and focusing on transporting samples to the laboratory, but we might think about a different approach through telehealth and then sending the tests and the samples by drones then afterwards. So that would be it, my presentation, to think about the self-testing as a decentralization tool. Thank you very much. Thank you very much, Alison. You have showed how it's important to decentralize the rapid tests in Brazil, but also the use of academic references and what the WHO is thinking about it. So thank you very much again. Now we would like to hear Ana Paula Fernandes and Carlos Sorgi, and they're going to talk about the plural study. Good morning, everyone. Can you hear me? Okay, great. Thanks for having me. My name is Ana Paula Moraes Fernandes. I'm at the University of São Paulo, and we're conducting the plural study funded by the university, and that is talking about inflammatory markers for HIV, AIDS, and COVID, including studies of the use of self-tests of antigens for SARS-CoV-2 for sex workers and healthcare professionals. Carlos Sorge is present at the event, and he will present our study, and then I will follow up on the presentation. Thank you very much for having us. It's great to be here, and Ana Paula, thank you for your kind introduction. Ana Paula and I are professors at the University of São Paulo in Ribeirão Preto, and we are scientific coordinators of this plural study. So now I'm going to show you a little bit of what we've been doing regarding this idea of decentralization of self-testing and how we are going to apply that in clinical research. So the plural study is recent. It was conducted in collaboration with other institutions, like the Adolf Lutz Institute, the CRT in São Paulo, the Barong NGO with large experience in serving vulnerable people and in situations of sex working and also in homeless people, and GermSure, which is working with us regarding tests for COVID-19. To give you a little bit of context, we had already been working with COVID-19 and studying the biomarkers of COVID-19 in cis populations. So we already had some important aspects that were discovered in the last year, especially regarding the pathology and how it was interfering in more severe cases of illness. So we knew that after infection through aerial airways, the virus was located in the lungs, and there an inflammatory process started. This is regular at the beginning for a viral infection, but then the inflammation was much severe. So that had to do with the immune response of the host, of the person infected, and that would lead to a cascade, a cytokine store. And we also found out that there were other mediators involved in this cascade. Besides the inflammatory cascade happening in the lungs and then was disseminated through other organs, that led to microthrombosis episodes and the leakage of fluids in the lung, and that would lead to a framework of acute respiratory inflammation, which is typical of patients in the ICU. So this is a demonstration of the inflammatory process. This is a review that our group published. And there you can see the filtration of, you can see all these cells and their roles. You have inflammation of vases, the cellular death, and then you see a higher amount of dumps that can cause inflammation. So this is a very complex process regarding the immune system, and it's important to study the role of each and every one of them. So what we know from the clinical side is that we have some biomarkers that are classical, that have been seen in most severe cases of COVID-19, like D-dimer. The increase of D-dimer was related to the coagulation problem, especially coagulation in the alveoli. Inflammatory cytokines were increased, the increase of neutrophils, and the decrease of lymphocytes. So that had to do with the immune response. And all these biomarkers together could show if the person was evolving towards a more severe case, or if that therapy implemented was being any effective. Afterwards, we found out that there were other sub-biomarkers which were also important and regarding the medical decisions, and these markers could be immunological or metabolic. So what we have in COVID-19 progression, especially in the first wave, where we did not have variants, is that we had a stair of evolution, and not all patients did die. The mortality rate compared to other viral infections is still low, around 2%. The problem is regarding the infections. There's a high number of infections, but around 50% of people had no symptoms. And when we divided population between symptoms, between mild, critical, and wild. So why did we have this large spectrum? Because we had people with symptoms and people who were actually dying. So what was the difference between these people? And what were the comorbidities, or what were the reasons that were causing this severeness? So with the first wave, we had an idea, and then the second wave as well. This is a study conducted with Brazilian population. So age was an important factor. In the first wave, we had more elderly people being affected with severe illness, and then we had other comorbidities related, such as diabetes or hepatic comorbidities, cardiovascular comorbidities, neurological and respiratory comorbidities as well, aside from immunosuppression. So all of those comorbidities combined with risk factors like age, and then the male gender, that was also a risk factor, that really led to the large number of deaths in part of the population infected with COVID-19. So regarding this background that we have been studying for over a year, our main question was, how do co-infections collaborate with this process of COVID-19, especially STIs, and how Since the male gender was a risk factor because of a mechanism dependent on testosterone, and we are about to publish another study on that. So how did transsexual people who were actually marginalized from studies, so to speak, so people who were doing hormone replacement, how are they inserted within the risk factors? So the idea was to study co-infections of COVID-19 and STIs and consider the hormone replacement therapy on trans people. That is how the plural study was born. So our main goals, considering this background of co-infections, was to analyze the usability of rapid antigen tests, as well as self-tests. And in our partnership with GermSure, we created the self-tests for COVID-19. Also analyze sex workers, trans people, and entertainment workers and their vulnerability of COVID-19 and their exposure regarding their working places. And also determine the immunological response of people who had COVID-19 and STIs. And with that, we would determine metabolic biomarkers, describe the immune response on those individuals, and so be able to predict or talk about the outcomes and maybe treatments or even the failure of treatments.
In total, our project have reached 1,500 people between patients and volunteers, and the project will be conducted in people's workplaces. We'll pick them up in their workplace and conduct a rapid test for COVID-19, HIV, HCV, HBC, and syphilis. And once individuals are tested positive, they will be divided into 8 groups, 4 initial groups, which are for cis individuals, and 4 groups for trans people. And the molecular studies that will assess the metabolic and the immunologic response will be developed in our lab inside the University of São Paulo based on the positive results of the tests and the different groups. But before looking at the result of the tests, we do a social study to assess the usability of the tests, the acceptance of such tests, with a social demographic study with all patients. And for those who test positive, we will also assess their peers and by donating tests so they can be tested at home. So we have established clinical protocols in our group, and they look at different important aspects regarding health and behavior of such individuals, and also research protocols with specific targets, depending, of course, on the molecular research that we conduct. So that includes the gene transmission, polymorphisms for some important genes as well, genes that are associated to a more effective immune response, and the biomarkers that are present in the plasma. So with this concept of decentralizing and using rapid tests, basically this project is only possible because of rapid tests. Otherwise, we wouldn't have access to these population groups, or we wouldn't be able to determine which individuals would be infected with COVID-19 or other STIs. So our protocol takes place on the street. The Barongi group has a lot of experience in approaching these individuals, sex workers and workers of night entertainment. And Baron has been conducting testing work in the work environment, a testing initiative in the work environment for a long place. So we have specific social and demographic surveys that we conduct. After that, we do the rapid COVID-19 test or the self-test that is being studied. We assess the usability of such tests, and if they test positive, we can donate more tests so they can take home to test their peers. After that, we do the specific HIV and other STI tests, and the results are shared individually, and they are sent to the different healthcare services depending on the result. If the result from a rapid test is positive for COVID or for any of the co-infections, we collect blood, and this blood will be used inside our lab for our research purposes. The self-test for COVID-19 is the immunoplasma for Viva-Diag. So people do their own nasal swab or a swab in the oropharyngeal area. It's a very easy test. When we were first assessing the usability, it was really well accepted without any major issue. And we were able to reach a population that wouldn't look for a COVID test, especially asymptomatic people. Now in the Omicron variant, we have a lot of people that are being infected by COVID and not developing symptoms or very light symptoms. So it's really important to detect these people so they don't transmit the disease in their work environments. Then we have the rapid test for HIV. It's a saliva test. It was mentioned before in the previous presentations. And we have hepatitis B, hepatitis C, and syphilis rapid test. In this case, we use a blood drop to conduct the tests. For the COVID-19 self-test that is being studied together with the James Soor team, we have a specific survey focusing on the usability of the test. So a number of questions that the person needs to answer. And this survey is also included when the person is tested positive and takes more tests home. And then they give us back so we have a general idea on the acceptance of these self-tests. Our target is to get better biomarkers and better therapeutic targets so we can improve patients' response to the severe infections. And so we can also have a trajectory or a pathway to do that in possible future pandemics. Having said that, I would like to thank you for the opportunity. We work in a very large team with people from different institutions. So again, Professor Ana Paula and I, we are the scientific coordinators of this group. And I would like to thank Flavia Pires from James Soor. They have been supporting us with the rapid test for COVID-19 and providing us with logistics support. And here on the slide, you see the long list of collaborators that we have from different institutions. Thank you very much. Thank you, Carlos. Very interesting information about the physiopathology and the immunology aspects of COVID-19. And the plural study to bring the COVID tests closer to people who are also suffering from STIs. We have some questions now. We have a question for Mariana that was sent by Aline Venturini, and she says, we do rapid tests for HIV and syphilis, but we have some difficulties, like getting authorization from the health surveillance service, and there's no standards for notifying the positive results. and she would like to know if this is true for the public service as well. Hi, Aline. Good morning. In the public health system, the HIV and syphilis test is still being studied, so it's not implemented in the public health system. So I cannot answer that question because we don't have that. Daniela will tell you more about the project that we have, but it's still not part of the public health service here in Brazil. So we will get more information on the project, how it's going, but these tests are still not part of our public health system. So we don't have a history. I couldn't give you an answer. I apologize. Thank you, Mariana. Daniela will be part of our next roundtable, so I think she will be able to give us an answer. Alison, do you have a prognosis on the agenda for decentralizing the service to help manufacturers for the different samplings? We follow the WHO guidelines, which talks about the strategies for collecting the samples and how they should be included in the health service, but there are no details in validating the samples. Some manufacturers already do this validation process. We have comparison studies that compare basically a self-sample and the sample that's collected by health professionals, and they assess the performance of one model in comparison to the other. And if the results are satisfactory, these instructions are incorporated in the directions of use, and there's no detail for the validation process. Thank you, Alison. Now we have Ana Paula. Ana Paula, how do you see the future of self-testing for COVID-19, considering the experience that we have with HIV self-testing, and what are the lessons that you learned from the Plural study? Professor Ana Paula? I think I can answer it. Maybe Ana Paula can contribute later. Could you repeat the question, please? Oh, there she is. Hi, could you please repeat the question? Yes. Considering the Plural study, you learned, or do you have some experience with the COVID self-test? And how do you think the COVID self-testing strategy will work in Brazil, considering the experience you have with the HIV self-testing? Certainly, we have great numbers for COVID, and this study is an academic study that is conducted by researchers from the University of São Paulo. And without a doubt, this study can provide us with information and help in the development of strategies to reduce, or better, to have a better diagnosis and to reduce the spreading of the disease. So this is our goal, using self-tests for that purpose, because on our study, we are assessing usability. So we have a survey that will be answered by everyone conducting the self-test. So we identify needs of adjustments. So in the end, we can truly use self-tests to detect the SARS-CoV antigen and as a strategy in public policies to prevent COVID-19 in our country. If I may add something, it's very important. We have this idea behind self-tests and how self-tests can be used in public policies. But when we have a study like ours, we know that the virus, SARS-CoV-2, is not going to disappear. It's in our plan and it's going to stay here. So the best policy is for people to get tested when they are suspicious that they might have it. Especially when we are going back to normal life, people are leaving their houses. So as soon as someone feels anything, gets a symptom, or is exposed, I don't know, maybe in a party or in an event, it's very important for these people to be tested So I think that in the future, we need to establish this policy, and it should become a part of our routine, so we can have a better quality of life and go back to normal life. Thank you very much to everyone who was with me this morning. Thank you, Mariana from the Ministry of Health. Thank you, Alison, also from the Ministry of Health of Brazil. And Paula, thank you for being with us. Thank you, Carlos. Thank you again. Thank you, everyone who has been with us. Now we are going to have another roundtable, and we will talk about self-tests for COVID-19. And let's see if this is a reality or not. We will start in a few minutes.
Vamos a invitar al siguiente.
So, let's invite our next moderator, Mr. Claudio Maierovich from the Fiocruz Institute, and he will be moderating the next roundtable. Carlos, good morning. Good morning, Segundo. Thank you very much to the organizers for the invitation and the opportunity to be here. It's very important when we think about the technology development for diagnosis, and especially right now, when we have a public health emergency. It is important to find new solutions, fast and possible solutions that allows us to move away from this epidemic. The topic of self-tests, without a doubt, is part of the agenda. And I believe that right now we have two different dimensions. One is what I mentioned before, the fact that this is an emergency. And from what we have learned from the global experience, there have been many advancements, and self-tests have played an important role, not just to detect individual cases, but also to ensure the safety of the different communities and different workplaces or different events that people might attend. Because people with a self-test can protect themselves and protect others. But this is also a trend that was really well presented by the researchers and the professionals from the Ministry of Health, because this is a trend that brings more autonomy to people so they can take better care of their health and get a diagnosis and, of course, start adopting different protective measurements depending on the results. I like to remember that years ago when I was working at Anvisa, before the approval of self-tests and many rapid tests, we had a very strong discussion about the risks associated to self-tests. And we would speculate on different possibilities of how much a pre-test advice would be missed or a post-test advice would be missed, and the risks that could be associated to a positive or a negative result. We have studied that, and here I can say that as far as I know, the team that was working on HIV and STD should be congratulated on the important work that they did, because they were able to transform these new technology advancements into important tools that have been contributing for the control of the diseases.
So I'm the moderator here, and so I would like to invite our speakers, Selena Shokin and Marta Suarez from FIND, to talk about COVID-19 self-testing from the bench to the user room. The floor is yours. There we go. We have the presentation up.
Buenos días y buenas tardes. ¿Me pueden oír bien? Mi nombre es Marta Fernández Suárez y soy la directora de tecnología de FIND.
My name is Marta Suarez. I am the Technology Director at Find.
Muchas gracias a Carlos y a los organizadores por invitarnos
Thank
a
you so
participar en este
much,
evento.
Carlos,
Y
and
gracias a toda la
everyone for the
audiencia por cedernos
invitation
su
to
tiempo.
participate in this event.
En esta
And
presentación
also,
les
thank you
vamos a
for the
explicar la
audience for
posición y
watching
el
us.
trabajo que Find
In
está
this
haciendo en el
presentation, we
campo de
will
las
talk
autopruebas de
about
COVID.
Find's work
Terminaremos con una llamada
regarding
a posibles colaboradores para
COVID-19
apoyar las
self-tests.
actividades que estamos planeando en Brasil para el
And
año que
we
viene,
will end
en el
with a
2022.
request for collaboration for the activities that we foresee for 2022.
Pero primero, si me lo permiten, me gustaría introducir brevemente quiénes somos.
First of all, I would like to make a quick introduction about us. So since 2003, Find, the Global Alliance for Diagnostics, seeks to ensure equitable access to reliable diagnosis around the world. We connect countries and communities, funders, decision makers, healthcare providers, and developers to spur diagnostic innovation and make testing an integral part of sustainable, resilient health systems. Find was established in 2003 as a product development and delivery partnership, and we are a collaborator with the WHO. Find grew, and we enlarged our mission not only to support the development of new products, but also to increase access to low and middle income countries. Mariana, Alison, Ana Paula, and Carlos made interesting presentations about self-testing for HIV and also self-testing for COVID-19. So I don't have to, talk a little bit more about that. I would just like to emphasize that there were several tests that showed the usability and acceptability of HIV and HCV self-testing. WHO also recommends the HIV self-testing as an additional approach, and HCV as well, up from this year. On this slide, I would like to highlight that, like previously mentioned, there are several models so that self-testing can be implemented in a variety of settings. They can distribute it in communities, clinics, pharmacies, or can be sold online. They can also be part of a company's program for employees. It's important to highlight as well that the lack of monitoring after the test is a concern in communities in situations of vulnerability, so we have to support them. We know that models based on performance with self-testing can be supported by a healthcare worker, and that showed an impact in the adoption of self-testing. Also, different types of support can be employed to facilitate the implementation. These instructions can be on paper, by video, or other systems like in person or with direct supervision. Like previously mentioned, there is a highly successful experience with HIV. So I will not be long on this slide. I would just like to explain a couple of successful examples. Moving on to COVID-19. With the pandemic, and at Find, we believe that self-testing have the possibility to increase the self-test and decrease the burden on the healthcare system. It is clear that this is a strategy that allows traceability and it prevents the transmission as well. There are several studies that shows that the antigen tests are fundamental to break transmission of COVID-19. And the low cost and the rapid results are also important. It's important to highlight that these tests, some of them are very sensitive to detect highly infectious cases. So these antigen tests increase accessibility, free up the capacity from healthcare systems increase the feasibility of serial testing, help improve containment of positive cases, and foster patient-centered care. Self-testing also gives people the opportunity to test discreetly and conveniently at home. Throughout months, we have seen how much the demand oscillated considering the waves in each country. So it's probable to increase next year if the number of cases increases as well due to the Omicron variant. Moving on now, I would like to show you this chart about the inequality of access of COVID testing. So here you can see the tests conducted by population, by country, and income group. This is a classification by the World Bank, and this number increased from the beginning of the pandemic, but in an unequal way. The blue line is of high-income countries, and our data shows that COVID tests in low and middle-income countries is much lower than in high-income countries. This graph shows similar results.
En este caso estamos mirando la misma métrica.
In this case, we are using the same metric. So it's the number by 100,000 inhabitants, number of tests by 100,000 inhabitants, considering an income group. So here in this line, you have the countries in the Americas. The lower and middle income countries are around 10 and 100 tests by 100,000 people. That's much lower than the high income countries. Considering the charts that I've shown, the goal is to increase self-testing and increase the capacity of countries to conduct self-testing. We believe that this is a very important tool to increase those numbers. It's important to highlight that since the beginning of the year, countries, high-income countries have implemented mass testing. The United States announced a billion purchase of rapid tests and recently announced expansion of their private insurance coverage. High-income countries have also a wide range of implementation approaches in terms of reporting their results, selling tests in pharmacies, supermarkets, online, and delivering at home. There are also examples of self-testing in workplaces, like in the UK, Singapore, in schools, in the United States, and also to serve events like Australia, for example, as they go on to reopen. In contrast, a limited number of low and middle income countries are implementing self-testing in Southeast Asia, India, Thailand, and places like Georgia. In most cases, the access of self-testing is over-the-counter at pharmacies with no government program. Some examples of governmental programs are in Thailand, where there are 8.5 million free self-tests available nationwide. In Malaysia, there are school testing programs, and the self-testing policies are likely to lag 6 months compared to high-income countries. We believe that Brazil and other Latin American countries have an advantage, which is the ability to address its limitations. In this test, we have some questions that we normally pose of the concerns that come up when we talk about self-testing for COVID or other diseases. For example, one of the questions that we hear a lot is, what if we lose track of the cases? A lot of countries showed that it's possible to implement digital systems to report the results and prevent authorities to lose the number of cases. There's also a fear of discrimination if the positive results are published. We believe that this fear is valid not only for self-tests, but for all tests in general. People may change their attitude in that sense depending on other factors. And the ability of people to conduct the tests properly. We've heard some opinions of colleagues before us, and there are guidelines that can actually help people to conduct the self-tests properly. So this is our FIND approach. We have identified 3 key components. First, the technology development, working with manufacturers to develop affordable self-testing solutions. Then the policy development, generating evidence and data, and the interventions in the market, understanding demands, ensuring adequate supply. FIND is also planning activities for this year and next year regarding these 3 components. On this graph, you can show the interaction between each area, but regarding technology, we're working with 6 diagnostic partners with their self-testing packages, and we will start the assessment of the performance of tests at the beginning of next year. Regarding policy development, we are conducting various studies to improve the perspective of national stakeholders. We conduct studies regarding values and preferences in 9 countries and studies on feasibility of self-tests. There are also studies on regarding cost-effectiveness modeling. And lastly, we are also planning several pilot programs in various countries, including Brazil. I will touch on that a little bit later. This is another example regarding costs and the volume of production with the companies that we work. The names of the companies are confidential right now. All these prices vary between $1 and $2. The manufacturers have committed to between 10 to 30 million tests per month. Regarding studies on preferences and values, this is a study conducted in 9 countries, among them Brazil and Peru. And this is a study of quantitative and qualitative methods. We study 4 themes in different populations. First, we have the value of COVID-19 self-testing, current testing, accessibility, and preferences of tests. These are some of the preliminary results of Brazil and Peru. We're still analyzing data. This is data collected in São Paulo and in Lima. We can say that in São Paulo, half of the participants responded that they would use a COVID self-test, and the large majority would report positive results to public health system. In Peru, around 80% of respondents would use self-test, and the vast majority would also report positive results to public healthcare systems. FIND is also conducting an online survey with similar questions regarding the self-testing. And countries are presenting similar results as well. But in Brazil, they are a little bit different, and that could indicate that in Brazil, there are more regional differences. In São Paulo, the survey has representatives from the whole country, and these are the results for Brazil only. The vast majority would self-isolate after getting positive self-test results. On average, they would be willing to pay 15 reais per test. We will keep on publishing these results because this is a very interesting and valuable tool for countries.
Now,
I would like to invite my colleague, Celina Joaquim, that will share results of the self-testing market assessment and access strategy. I apologize, but I will present in English.
So I'm going to present on a study that we did over the summertime in July and August in 8 different countries to understand the market for COVID self-tests. And this work was done as part of the ACT accelerator work that FIND co-leads for the diagnostics pillar. And as you can see, we studied 3 countries in Asia, 3 in Africa, and 2 in South America, including Brazil. And our purpose was to understand the use cases for self-testing, the segments, and what were the enablers that would increase access and use of self-testing. We also wanted to understand the enablers in each country and to do a model to understand what the market size could look like for self-testing, and then what actions would increase the use of self-testing. Next slide, please. To do this, we conducted over 110 interviews with different stakeholders, and we read a number of different reports and databases. But I also want to stress that this is a very new product. It's in a fluid, nascent market, and things can change very quickly. If there is a new wave of COVID cases, for example, the market could change quite a bit. So these were our estimates based in July, and I will talk through some of the places where there may be some changes since that time. Next slide, please. So first, we wanted to understand use cases where self-testing could play a role. And the green are the use cases we considered, and purple are the ones we did not. So, for example, in work, we looked at large corporations, public sector employees, healthcare workers, micro, small, and medium-sized enterprise employees, and informal workers. We looked at travelers. We looked at different cases in education for primary and secondary schools, both the students and the teachers, as well as tertiary education. We also considered large gatherings, such as a football match, or a church event. We also looked at individuals looking in congregated settings. And then in the health use cases, we looked at exposed and symptomatic individuals. Next slide, please. Then we considered the enablers that would enable the use of self-testing. And the first 2 enablers in any country to allow self-testing is whether the product is authorized, because of course it has to be authorized in order to be available in the country, and the policy. So who can use the test and what are the policies around its use? And those are really the first 2 critical enablers. Once those are available in a country, we then consider supply and procurement, individual accessibility. Can the individual find a test and access it? Funding. Is there funding available? How will the individual pay for it? What is the price? And is it too expensive or is it reasonably priced? Are patients motivated to take the test? Do they know about it and do they want to know their test status? And finally, reporting and monitoring. Is the patient able to report their results? And is there trust in the system from the Ministry of Health and others that patients will report their result. Next slide, please. So what we learned across the 8 countries, and we have a lot of additional information, but just to give you a sense, is that around product authorization, the value proposition of self-testing compared to professional tests is still somewhat unclear and misunderstood, including at the Ministry of Health. And some of that is because the WHO has not yet evaluated the use of self-testing for COVID. And so there's still some confusion, but WHO is now in the process of considering self-testing. We also know that regulatory approval can take a very long time in many countries. On the policy side, there are no normative global guidelines from WHO or others that would guide self-test policy. And policy tends to be very decentralized. We also found that as vaccinations increase, there may be a decreased perceived need for self-testing. And this will be a challenge going forward, is that there's a very strong focus on vaccinations, and some people might not understand we need both. For supply and procurement, many countries have a lack of local supply of high quality tests. And COVID-19 procurement might be very focused on the vaccines, as I mentioned earlier. For individual accessibility, there's often a limited distribution network, especially once you get outside of the larger cities and towns. And sometimes in many countries, self-tests cannot be sold in pharmacies or in shops, which makes them harder for individuals to access. In many countries, the cost of testing could be a barrier, especially in serial testing, which would be in a workplace or in a school. And many countries have limited coverage for insurance or for public sector purchasing. Patient motivation. We found that there continues to be some stigma associated with COVID-19, although that has gone down quite a bit. And in many countries, COVID-19 testing is not perceived as a big need by some segments. In reporting and monitoring, there is limited confidence from the government and from employers that people will take the test properly and report properly. And we found that many reporting systems can be difficult to use, but this varies by country. There are limited systems to monitor and enforce the testing. Next slide, please. So to go into each country, we wanted to first start looking at the current self-testing enablers. And across these 8 countries, at the time of our study, India was the only one where self-tests were currently authorized for use. You can see that the green gives you a positive view of the enabler, yellow is mixed and red is negative. And in India, they have self-tests authorized, but they have limited use cases only for exposed and symptomatic individuals. Supply and procurement is generally not a problem. The tests are available widely online and in pharmacies. Funding can be a challenge, but the cost of self-testing is lower than for PCR and professional antigen RDTs. And there was increasing awareness around getting tested. So this was the only one, but I do want to stress that a number of countries are moving towards self-testing. So beyond India, especially in Asia, we've seen an increase. So Thailand, Cambodia, Malaysia. We understand that the Philippines is very close to authorizing self-testing, and there is also some effort in Indonesia. So particularly in Asia, we see a movement, but at this point, among these 8, it's only India. If we go to the next slide, please. Now, this is a bit busier of a slide, and I'm not going to go through all of it. But what I want to show you is a sense where we're looking mostly for countries that have yellows and greens and fewer of the yellows and reds. So in Asia, India was certainly the most positive environment, because here we would just focus on increasing access beyond the exposed and symptomatic individuals. As I mentioned, the Philippines is very close to approving self-tests, so it's moving in the right direction. And we also understand that Indonesia is considering self-testing as well. In Africa, South Africa was probably the most positive amongst these three countries, but they did want to wait for approval from WHO before moving to self-testing, and that could be a few more months before that decision is made. But they would be able in South Africa to procure the tests, and they had multiple channels to distribute them. In Kenya, there was some possibility of moving to self-tests, and they were considering pilots. But in Nigeria, at the time, there was less interest. They also had fewer cases of COVID at the time we did the study. And in Brazil, I will go into more detail in the next slide, but just to compare Brazil to Peru, Brazil is a more favorable environment for self-testing. In Peru, this would require a number of changes in legislation, and we did not find strong political will, and there would be a number of changes needed to be made in distribution channels for individuals to be able to access the tests. Next slide, please. So to go into more detail in Brazil, as you know, self-testing is not currently approved. They would not require in Brazil to wait for WHO for EUL and could potentially consider a US FDA approval. And we know that there is some ongoing discussion about self-testing, but it is not yet, a decision has not yet been made. On the policy side, there is, of course, an increased use of antigen professional testing, but self-testing is not in the national guidelines yet. There is a testing plan, which was launched in September of 21 that does follow WHO guidelines. And we found potential demand for certain niche groups, such as people in remote areas, sales workers, and education. But we did not find it as likely to be used for employers and in higher education because there is already a health professional available on site. And there were some questions about reporting at this time. On supply and procurement, we did not find that this was generally a problem in Brazil, and it was quite favorable. For individual accessibility as well, there were a number of potential channels for pharmacies and public health facilities, and potentially even the postal services in individual accessibility for access to the tests. For funding, the tests would not be covered by insurance, and employers are unlikely to finance the self-tests, but the tests would be likely affordable for the middle class that are already accessing antigen RDTs. On patient motivation and information, there is a new testing campaign that was launched in September. There is some misinformation available, and there is a concern from some health officials that the population might not follow the instructions correctly. And on reporting and monitoring, there is an app that's available for self-reporting, but some questions about how that would be used. Next slide, please. Now I want to move into the modeling to show you how we understood the potential market. So we started with the segment size, which is the total population in the user segment, such as large private corporations, multiplied by accessibility, the percent of the segment who might be able to gain access to self-tests in practice, multiplied by the adoption rate, so the percent of the segment with access to self-tests that might choose to use them, multiplied by the usage rate, so how often they would use the test, if it was once because someone had symptoms, or once per week in a workplace or a school. And that gives us the total use. Next slide. We had 4 different scenarios we modeled. So first is our current use. So that was, if you'll recall, only in India across these 8 countries, and only for exposed and symptomatic individuals. Number 2 is extrapolating our current usage in India to all 8 countries. So the symptomatic and exposed individuals in all 8 countries. Number 3 is our theoretical maximum based on use cases. So in the places where we heard that certain use cases would work, we turned those on or off. And I'll show you this in the next slide. And number 4, we turned on all of the use cases in all of the 8 countries to get our theoretical maximum. Most likely, the true answer is somewhere between scenario 2 and scenario 3. Next slide. So this shows you where we turned on the use case segments. And this was based on the interviews in each country. So you can see that in Brazil, we turned on fewer of the use cases, but we could turn them on and redo the model if needed. But in Brazil, we only turned on private schools, individuals going to leisure activities, and symptomatic and exposed individuals. And next slide, please. And this gives us the volume of self-tests per month for each of the use cases. And so you can see that if we look at scenario 2, that would give us 5 million units per month. And scenario 3 is 60 million units per month across all of the 8 countries. Next slide, please. And this shows you the potential use of self-tests in Brazil. So it's somewhere between 1 and 5 million tests in Brazil. And again, as a reminder, this was done in July, but we think this is fairly accurate. Next slide, please. So here we considered what are the most important policy actions that we could undertake in order to increase access to testing. And starting in India, which was one archetype, we would focus on policy, so expanding beyond the exposed and symptomatic individuals, as well as addressing funding issues. If we look at Brazil, as well as the other countries that were somewhat similar to Brazil in this study, these were countries with higher GDP, higher access to health coverage. Here in these countries, we would focus on product authorization, so getting the product approved in the country, and policy. And this really had the highest potential of self-test users, which was around 1.5% to 3% of the total population. And the best use cases that we found in these countries were the large private corporations and the public sector employees. And then finally, our third archetype, which was the countries in Africa, Nigeria and Kenya. And here was more of a challenge because we had to focus on 4 of the different enablers. And honestly, the upside was a bit lower. There were limited use cases and smaller potential. Next slide, please. And this is just to give you a sense of the different actions that we identified that could be taken to address each of these enablers. And I know this is quite a lot in one slide, but to give you a sense of which activities, which ones are colored, are already underway or being planned. So for example, working with manufacturers to seek WHO EUL or stringent regulatory authority approval, identifying local stakeholders to navigate the authorization process, supporting WHO to develop normative guidelines, launching trials, as well as establishing exchange and learning mechanisms. So really there are a number of different activities that could be taken to increase access and to address each of these enablers. So I think I will stop there and hand back to Marta. Thank you very much.
Muchísimas gracias, Celina, por tu presentación. Para terminar, solo nos gustaría hablarles de uno de los proyectos.
Thank you, Celina, for your presentation. To conclude, I would like to talk about some projects that we think about doing in Brazil and other countries. The main goals are to optimize self-testing package for 2 or more priority user segments, for example, schools and workplaces. Second, generate evidence to support national policy development. And the third, a pilot implementation in specific user segments. We are thinking about different activities. The first one is the number of workshops and interviews with national enablers, so that we guarantee that we are prioritizing the user segments properly. The second is a survey with target user segments before implementation of the pilot programs, so that we all have everything aligned at the beginning of the project. We also want to implement the pilot programs at the second half of the year. And this would be the end of our presentation. Thank you so much. And if you would be interested in participating or collaborating with our workshops that we are planning for the beginning of next year, get in touch with us. This is our contact email. We look forward to that. Thank you so much again. Thank you so much, Marta and Selena, for such an incredible presentation with such important information. And now I would like to hand over to Mohamed.
Good afternoon, good morning, good evening to everyone on the call today. I would like to thank everyone for allowing me to come and present. I will be speaking in English because my Spanish is not very good. And I hope everything is clear enough. So without further, can I continue? Is everything okay? Can I go ahead?
Yeah.
Audio?
Yes.
All right.
Go ahead.
Thank you. So today I've been asked to present on the usability of COVID self-testing, and I want to really involve with the HIV self-testing program in South Africa and globally over the last 6 or 7 years, specifically in terms of evaluation of candidate products for self-testing purposes. So the talk today is more around my experience from the WHO pre-qualification processes. It's a bit of a step back from the great talk that was just provided now by the fine team. So in terms of my presentation today, I'll be looking at the lessons learned from the pre-qualification of HIV self-testing and some of its applications for COVID-19 self-testing. If we go back to simplicity and go back to the basic, what makes it a product profile for HIV self-testing that was developed in 2014, which gave us an indication of what we were looking at to get from a good. We wanted a test which had high clinical and analytical sensitivity and specificity, a test that will give us low invalid or failure rates, instructions for use which had more pictures than words, and that was translated into local languages. We wanted as minimum steps as results which are simple enough to interpret, reduction in time to result, and stability of test results. And I think these principles stand true for all self-tests, whether it be HIV, hepatitis C, COVID, and these are some of the technologies that I've been involved in over the last few years. So I think going back to 2015, and when I started on this journey of evaluation of products, self-testing that existed at that point were numerous. But one of the main ones that existed was that there were no requirements from the WHO in terms of pre-qualifications for self-testing, and these were not defined. We're in a very similar space now with COVID self-testing as well. And I think a lot of the lessons that we have learned over the last 6 or 7 years on the HIV self-testing journey these lessons can be brought forward for us because we are now in a very similar space. So in the absence of having a framework from which to work upon for WHO purposes, and we work very closely with the pre-qualification team, Robin Muren and Irina Pratt and Anita Sands at the time, whilst they were developing the technical specification series for an evaluation framework, which we thought may be relevant and may be useful for HIV. Just going to turn off my video. One that went from non-clinical studies to looking at usability assessments, to trained user assessments, intended use, expected use cases. And again, we are talking a very similar situation now with COVID. So in 2015, we kicked off a program whereby, and this was prior to WHO pre-qualification guidelines, kicking off the program that looked to evaluate candidate HIV self-tests, utilizing that framework of taking products through the various stages of evaluation. Later that year, the pre-qualification team came up with a technical specification series, and it was very important that our protocols matched the requirements of the TSS. So if we look at the main requirements of the TSS, and now this goes for hepatitis C self-testing as well, and we think it will be something very similar for COVID self-testing as well. We took the product through two protocols, essentially, the first one being a usability assessment, where we wanted to understand how well could the test be used in the hands of untrained users. And with the various parameters that we looked at were label comprehension, mock result interpretation, and the overall product usability and failure modes. It was important that no demonstration or training was provided to the end users prior to the evaluation taking place. Once the product was deemed to have a high usability, we then took it to the next stage of evaluation, where we compared it to a gold standard. And for the case of HIV, we compared the performance of the self-test to the rapid test on the algorithm, national algorithm, and to an ELISA, fourth generation ELISA test as well. So over the course of the last few years, we've evaluated numerous products in the hands of untrained users, where we provide them with nothing but the test kit and the instructions for use, and ask them to go about conducting the test to ensure that we can determine whether the test is usable in the majority of the population. For this purposes, we looked at differing education levels, literacy rates, age, gender, ethnicity, so we could get a good mix of the South African population to understand whether those individuals with a low education level are still able to do the test, and how does it compare to higher education level. So we're quite experienced in this space. For HIV, we've evaluated over 8 or 9 different products in the course of the last few years, and quite a few of these have either got WHO pre-qualification or in the pipeline. Similarly, we've done quite a bit of work for hepatitis C self-testing in partnership with FIND, and now looking at doing something very similar for COVID self-testing. So we've learned the lessons for this. Of the products that we've evaluated, we have 4 products that have pre-qualification, and all 4 products were evaluated in our facility on the same standardized protocol. Through our relationships and partnerships with PATH and FIND and others, we've been able to set up a network of relationships of sites across the globe that conducts various assessments on similar or the same protocols, depending on the requirements from a prevalence perspective or strain perspective, as in the case of HIV-2 in West Africa. But we could look at high and low prevalence for the various disease states. And we've set up this network of partners where we can run similar interventions across multiple countries. So just going back to an example of the usability assessment and what do we actually track and how do we go about tracking it, the participants provided with a test kit and an instruction for use, no demonstration. An observer who's a professional nurse would sit back and record the specific steps of how the person conducts the test. And then we score the performance of the test according to the successful completion of each of the steps, calculating a usability percentage based on the average of all of the different steps, and then also highlighting which are considered to be the critical steps. What it allows us to do in this process is to go into those or hone into the steps which are problematic. So for example, in this example that I've provided, in step number 7, we saw that there's only a 68% completion rate on that specific step, we can then address that step with the manufacturer to tell them that this probably needs to improve if you are to improve your usability of the test. A lot of the data that we've looked at has been published, and I've just wanted to pull out an extraction from one of the tables where we could do a comparison of multiple self-tests across the same protocol with 900 participants across each, to show that we can measure and then compare products according to a single standard, utilizing a standardized protocol which allows this cross-comparability of the device performance. We also serve as an independent evaluator for WHO and not necessarily a WHO pre-qualification site. Like I said, in terms of recommendations for the further development of the tests, once the evaluations are completed, we can go back to the manufacturers and show them where people have made mistakes on the evaluations and how some of this can be fixed. Some of it is minor fixes. For example, in the picture that's shown, we've shown that just alignment of the picture to the actual buffer pot stand made a huge difference to the usability, because now individuals were not placing the buffer pot on the table and rather placing it in the stand as provided. So these subtle changes can improve usability, and it's something that we've done for numerous tests now to improve their performance. So to answer the question on COVID-19 self-testing, and based on my experience with HIV and hepatitis, do I believe it's a reality? I certainly believe so. However, the pathway which took us from the point of company-initiated R&D products to having a policy, and again, sorry for just citing a South African example, I work very closely with the South African program, but to move from the point of having a R&D product to government policy took a period of 4 to 5 years. And we know that with COVID, we don't have that 4 to 5 years. This took the products, at each step, the products had to be researched, they had to be evaluated. There were implementation use cases that needed to be evaluated. There was guidance that was needed to be put in place. And like I said, all of this took a period of 4 to 5 years. With COVID self-testing, we don't have years, we have months. And we've as a global society, have to condense this process into a much shorter time period. And this requires, with the unprecedented speed of development, it requires a lot of parallel processes to ensure that we reach the markets that are needed quite quickly. And I think that an important point is that it requires political will. Having been involved with the National Department of Health and the regulator in South Africa, I can see now how difficult it is from a single country perspective for manufacturers, for products, for donors to get approval of COVID self-testing in one setting. I can only imagine what that is from a global perspective for multiple countries wanting evaluation data. So I think we are all pushing towards the same goal. However, we have these parallel processes that are taking place. And I'm happy to see that my thinking is aligned to the previous presentation from the FINE team. So we've been involved in various processes and things that need to take place at the same time. We know that WHO are in the process of determining guidance on self-testing, and the WHO pre-qualification team looking at the requirements for the technical specification of these products. I think it will be good to have a set of pre-qualified products so that countries don't have to do country by country assessments of these products. The regulatory requirements for each country needs to be determined, and I think in the absence of global guidance, leaving it from country to country is going to make it very challenging. The development of policies and guidelines for usage of these test kits needs to happen concurrently, but that can only happen if we know what use cases we're looking at. And as identified in the last presentation, there is very little implementation taking place in low and middle income settings, and much of the usage of both professional use antigen testing and self-testing has been in higher income countries. And we know that the use cases that are utilized in higher income countries cannot necessarily translate to lower middle income countries, especially with the usage of digital tools. There is a learning curve. However, I do believe that in a country like South Africa, we certainly would welcome the usage of COVID self-testing. And I think I can speak for much of sub-Saharan Africa, where HIV self-testing has been something that's quite commonly used, with over 6 million tests being distributed over the last few years. There isn't a sort of inherent knowledge of self-testing that already prevails in the market. There's various market shaping interventions that we've seen from the FIND team as well, which will be hugely beneficial, especially when it comes to a cost perspective and a volumes perspective for lower middle income countries. As we saw with the vaccine inequity, the lower middle income countries have been left behind. So in terms of us establishing usability amongst end users, there are certain things that I think we need to consider, and this is just based on some of the other products that are some of the other evaluations that I've completed. Self-swabbing is not the same as a blood finger prick, and difficulty in a lay user determining adequacy of a sample. So has the participant or the individual swabbed their nasal passage well enough, high enough, long enough, to get an adequate sample? How would they know? And how would they be able to determine whether the sample they've produced is adequate? And we're not seeing a negative result on the basis of it being an inadequate sample. It really comes down to the actual product that we're looking at and how easy it is to actually complete the test. Timing of the test, and how do we convey the message of when is the best time to use a self-test in terms of symptoms and in terms of contact with a positive, that window of sort of antigen, the best performance of the antigen test between 3 and 5 days post-contact. How do we communicate that to the end user? There are a lot of interventions around test and treat, which are starting to take up. And how can we utilize the self-test for these interventions? Are we still going to rely on somebody getting a second test, a PCR test, a confirmatory PCR test, and losing very valuable window time? Or can we rely on the result of a self-test for test and treat interventions? And I think usability and result interpretation in low middle income countries is always going to be important, where we do have lower literacy levels, especially within rural settings. So these are some of the things that we need to consider when evaluating products and when thinking of which products are more suitable for which market. So we're part of a program working very closely with the FIND team in terms of evaluating usability and performance of candidate tests, which we're hoping we'll be able to start by June 22. The protocol has been developed in consultation with WHO to ensure possible future alignment with the technical specification series. So we're hoping to get really stuck into these evaluations and take out the learnings from what we're seeing, so that we can utilize it for the global market, similar to what we've done for the HIV program. Thank you. That's my presentation for today, and I'll be happy to take any questions.
Muito obrigado, Mohamed, pela interessantíssima.
Thank you, Mohamed, for your very interesting presentation. We have a few minutes left, and first I have a question for Selena and Martha from FIND. They have presented a very interesting material, but how do you see the experience from different countries that are already using a self-test, especially European countries, how they are using self-tests to control COVID-19? Martha, Selena?
I can start, Selena, and you can chime in as needed.
Eu
you want.
posso começar.
So we see different experiences in the high-income countries, and I would say the experiences have changed over time as well.
And these experiences have changed over time.
Studies that were done on some of the initial implementations were perhaps not completely embedded in a system that provided a structure and provided enough instructions and support to the individuals. I would say that has evolved over time, and programs are now being a lot more effective. In many of the high-income countries, still the majority of the programs are based on pharmacy and online retailing. Some of the countries are also including requirements for reporting that are allowing the participants to report the results. So I would say there is a lot of room for improvements. Some are more advanced, some are less, and some countries have to scale up to the whole population, like UK or Singapore, whereas others are focusing more on specific segments, like being in a school testing or in the workplace. It's very important that each program is really tailored to the country and the reality of that country. And it really depends both on the healthcare system as well as the school system or how the workplaces are implemented. So that's why, for example, in the pilots that we're going to be conducting in these 3 different countries that we have decided to focus, we are going to be focusing on specific segments and designing those pilots to be very tailored.
Thank you. Selena, do you want to add something?
I apologize because I did not understand the question in Portuguese. Can you summarize it?
Yes, I was asking you, how do you see European and many countries, usually high-income countries, have experiences with self-testing?
Well, as Martha said, I think the higher income countries have a varying amount of experience, and the European countries are doing really quite well in getting out the self-tests. It's been a bit more of a mixed experience in the United States, for example. What we're trying to do is to show examples of countries, even in low and middle income countries, that are doing a good job with self-testing, such as Malaysia and Thailand and Cambodia, and to share those experiences more broadly, because we think this self-testing should be an option for all countries and not only the high-income countries.
Thank you, Selena. And now I'll bring a question to Mohamed also. Mohamed, in this pandemic, we've been seeing WHO make recommendations like treatments and testing, diagnosis. It was not usual. Do you believe WHO will take a position about self-testing, maybe going beyond the technical approval and making recommendations for using a NOTIS in different kinds of countries?
Yes, I think absolutely. I don't see why and how they should not do so. Depending, it really comes down to timing and having enough evidence to suggest that they can be making a recommendation on the usage of self-testing. So I think as evidence gets generated, WHO will definitely come to the party with guidance for countries. I don't think at this point we have sufficient, but like I said, so many things are happening in parallel. We first need good products before we can get to the stage of implementing and testing out these products from global perspective. But I do think by end of Q2 next year, there should be at least some sort of indication from WHO on the usage of the tests.
Thank you. Bom, obrigado, Selena, Marta, Mohamed.
Thank you, Selena, Martha, Mohamed. This was a very interesting panel, and we will be talking about it in a while once we have a larger use of these technologies, because this is a very moment that we are defining basis, technical basis, legal basis, political basis for interesting and important changes. Thank you so much. Thank you, Carlos, again for having us and for inviting me to moderate this panel. Claudia, it was an honor to have you brilliantly moderating this discussion. Martha, Selena, and Mohamed, thank you so much. It was a very interesting presentation about your experiences and about the future projects, and that will help us a lot in our region. So thank you again. And I invite you for to watch the next panel on technological incorporations in the public health system in Brazil, what to expect in 2022. Álvaro Puccinelli is a scientific director of the Brazilian Society of Clinical Research, is going to moderate this panel. Álvaro, thank you so much for being here. The floor is yours. Thank you, Carlos. Thank you for everyone watching us online. It's an honor to be here. This is going to be a very interesting panel talking about specific aspects for laboratory research regarding the incorporation of new technologies. We have been working a lot on that. Well, this panel will have 5 speakers. The first speaker is going to talk about tuberculosis, Dr. Erica Chimara. Afterwards, we will have Dr. Marianne Stefani talking about a rapid test for leprosy. Then we will have a talk about the duo test of HIV and syphilis, Daniela Cristina Soares. Afterwards, we will have Pamela Gaspar from the Ministry of Health talking about chlamydia and gonorrhea. And then Dr. José Levy from the University of São Paulo will talk about HPV. So thank you all. I would like to hand it over to Dr. Erica for her presentation. Thank you. Good morning, everyone. Thank you for having me at such an important event. I would like to thank Dr. Carlos for inviting me and Dr. Flavia as well. And thank you all for the opportunity to show you a little bit of the work that we do here. Let me share my screen with you. 1 second. Please let me know if you can see it in presentation mode.
Assim, doutora, pode continuar.
Yes, go ahead. Okay, so we will talk about the incorporation of a test at the public healthcare system in Brazil that was recommended by the WHO, and it's going to be incorporated here in Brazil. So what are the expectations of the service? So the infection caused by Mycobacterium tuberculosis is a curable and preventable disease. So we have 85% of people that develop the disease treated successfully within 6 months. To conduct the diagnosis, we have basic tests. A test of Bacillus copy developed over 100 years ago. We also have rapid molecular tests, which are recommended by WHO since 2010. And we have the culture test that takes about 8 weeks to provide the results, but it's still the gold standard. So now in 2020, we have data reported by WHO showing that almost 10 million people fell ill with TB. We've had a huge problem because of the pandemic, because there was a gap of people undiagnosed or not reported. We've had 214 people that died with HIV and 1.5 million people who died from TB. The strategy established by WHO to end TB is to define latent infection of TB. So we have to make the diagnosis to fight the disease as a whole. So latent infection is an immune response to the antigen, but there's no evidence of the disease. So people do not have symptoms, but they are at risk of getting ill. Between 5 and 10% of people with ILTB, if not treated, will develop TB throughout life. There's no gold standard to identify this infection, and most of or the biggest difference between ILTB and TB is the absence of disease. So how do we do the diagnosis? We conduct clinical, radiological, and laboratorial assessment. We have tuberculinic proof at the laboratory, which is the intradermal inoculation of a purified proteic derivative, which will measure the cellular response to the antigens. So we have a read 48 to 72 hours after the application. And so we need 2 appointments to conduct this test. The interferon gamma release assay is an indirect test that will detect the infection, detecting the production of lymphocytes considering certain proteins produced by M. tuberculosis. So we might have a positive, negative, or undetermined result. We have seen the benefits of IGRA test compared to PPD. One of them is that the IGRA test is conducted in a single day. So the patient goes to the healthcare clinic and does not have to come back. With the PPD test, the patient has to go twice because the technician has to perform the read and interpretation of the result. IGRA has a high sensitivity, a high specificity compared to the PPD test. The PPD test can be variable in people vaccinated with the BCG, with the TB vaccine. We have a false positive results there. So we have some advantages on the IGRA test. This is a test recommended by Conitec in Brazil in October 2020. It was recommended to detect a latent infection by M. tuberculosis for patients living with HIV, reminding that they have to have a TCD4 above 350 cells per mm3, and people candidate to transplant of stem cells. It's important to test these people, but right now, Conitec does not recommend the IGRA test for this population, but the evaluation is undergoing. So Quantiferon Tb is a test for in vitro diagnosis of this infection using a blood sample. It uses a set of peptide to stimulate the cell in the blood, but these proteins are present in some cells. So when they're not present in BCG strains, is the cause of having some false positives because these proteins might be in M. kansasi or M. marinum strains. So people infected with M. tuberculosis have lymphocytes in the blood that will recognize these mycobacterial antigens. So this test has to be performed in 4 tubes for positive control, negative control, and here they will primarily detect CD4 T cell response. So here we have the difference between the IGRA and the PPD test. The detection of interferon gamma will be performed by the ELISA test to identify this antigen proteins. So the detection and quantification will be the base of the test. SUS has then incorporated the IGRA test in November 2020, 1 month after being approved at Conitec. So the Ministry of Health is working on implementing this test in the laboratory network. And in August this year, they required all coordinations working with TB of a proposal for a network, laboratory network. I'm coordinator of the network in São Paulo. And so we are checking all the laboratories to see if they have the proper structure to conduct these tests. So what are the needs that we have? There are several requirements. This is a very important implementation, and we have to evaluate key aspects in order to be successful. So we thought about implementing a pilot program together with GENSUR and other coordinations of TB programs and HIV programs to implement the IGRA test. So what are the minimum requirements? The ability to collect blood samples, the guarantee that there are logistics to quickly transport the blood samples to the laboratories in a proper time. The laboratories have to be centralized in order to optimize the use of the kit. And we also need laboratories that can process and read and deliver the results in a way to have the technicians and work according to quality standards. In the laboratories, we have to have equipment and inputs to perform this test. It's not such a simple test regarding infrastructure. So the pilot project that we implemented in the state of São Paulo has as a goal to evaluate the main bottlenecks to implement such a test in the diagnostic routine. So as we've seen, it's important that the diagnostic is conducted with tests that are specific. But once we start using this test in the laboratory network, we have to evaluate the whole population that will be studied and also the infrastructure existent to perform the test. The pre-analytical or post-analytical aspects may influence in the quality of the tests. So we will evaluate the laboratory conditions, logistics, and also the layout of the result. So we will use 10 different laboratories located in the state of São Paulo. We have 4 labs in the city of São Paulo and other 6 ones in different cities throughout the state.
Our first goal is to assess the labs. So we send them a survey, a questionnaire, asking about equipment, materials, the staff, and the standardization of the protocol. After that, we need to assess the logistic aspect. It's important to determine the transportation time because there is a maximum time the material needs to be processed. I also need to assess the material used for the sampling and the level of the lab. Distance is very important because we need to control the temperature of the material. And many times, the time it takes between the place where the sample was collected and the lab where it will be processed, temperature can play a big role. The different type of tubes, it's different collecting a test in the tube that where the test will be conducted, and a different type of tube, what is the difference in terms of result. And we also have a difference in terms of the lab level. We have labs that are inside healthcare centers, so the time to conduct the test will be much shorter than a lab that will be receiving samples from a different center that might be located in a different city. A work that was recently published by the Report Group, they studied in two state capitals, Rio de Janeiro and Manaus, the implementation of the IGRA test. And they identified that temperature was one item that affected the quality of the test. So the lab is another important element here. And in this work, they were able to demonstrate that the different health clinics that send samples to these labs, this model can alter the results because the distance, the temperature, the time, and the type of transportation play a role in the result of such tests. Another important issue for the pilot project is the assessment of the layout of the results and how they are reported. We need to provide a qualitative information. The test was positive, negative, or non-determined. But we can also provide the same information.
A concentração de interferon gama que foi detectada no teste, nos tubos, que são, no caso, o TB1 e o TB2.
Different information like TB1 and TB2. What we also have in the literature shows that the level of interferon gamma has not been connected to the level of infection or to the level of the immune response or with the probability of the progression of the active disease. But this work is also interested in assessing that element. So assessing if that information together can be important for the decision-making process that physicians will make for the latent TB infection. So it is very important, and we have the expectation that the implementation of the IGRA test will cause an impact in the improvement of the lab infrastructure. But it is essential that we have an agreement in the transportation and in the scheduling plan for the material. We need to plan the acquisition of the different raw materials. We need to provide technical training to all professionals that will be part of this implementation. And we need to establish a centralized implementation plan with a decentralized approach. So in that way, we will be able to have this test so lab can develop and execute the test the best possible way without having any losses in the pre-analytic and in the post-analytical stages. So this is one example of the implementation of a test, but this model could be used for the implementation of others, because we see that especially in the public health sector, there is a great impact in terms of infrastructure and the impact that infrastructure has in the quality of the result. I would like to thank you for your attention, and I would like to thank the state programs for TB that support our lab and the program that we are conducting. And we hope that the implementation in the state of São Paulo is successful as the result of our project. Thank you very much.
Muito obrigado, doutora Érica.
Thank you for your excellent presentation. We have already received some questions, but now moving forward on our agenda, I would like to invite Dr. Marianne Stefani, and she's going to talk about the rapid test for Hansen's disease.
Estou aqui, vamos compartilhar a tela. E sempre estresse na hora de compartilhar a tela.
Always a bit
Não sei se vocês estão.
É a frase mais dita nos últimos 2 anos. Vocês estão me vendo e estão me ouvindo? Isso é... Você já...
Não sei se vocês já estão vendo.
Can you see my screen? I don't know if you can see it. Not yet.
Vamos ver de novo.
Let me try again.
Acho que agora vai, né?
Agora vai.
Is it working?
Só precisava tirar aqui. Então, eu quero agradecer muito.
So first, I would like to thank the organizers for the invitation to talk here. Thank you for the opportunity to discuss this topic, which in my opinion is very important. It seemed like a dream to have some sort of rapid test for Hansen's disease, but thanks to the joint effort from many researchers and many people, we are finally getting there. First, I would like to share some data on Hansen's disease for you. Every time I went abroad to talk about Hansen's disease, people would look at me with a weird look on their face and ask me, is this disease still around? Unfortunately, it still is. Every year we have more than 200,000 new cases. Unfortunately, Brazil is the second country in the world in the number of new cases after India. And there's an interesting element in 2020, and I think this will be true for other diseases. We saw a reduction in the prevalence and in the occurrence, but unfortunately, this data reflect the impact of COVID-19 and the impact that the pandemic has had in the care provided to other diseases. And I'm sure this will be true for other conditions as well. Brazil, India, and Indonesia, they concentrate the vast majority of new reported cases of Hansen's disease in the world. It's a treatable disease since the 1980s. It's a disease caused by a bacteria, so we use a combination of antibiotics. Despite the fact that this is a very effective treatment, the prevalence is going down with no impact on the occurrence. There are 2 treatment protocols available, one with 12 doses for patients that have a higher bacillar load, and a treatment with 6 doses or 6 months for patients that have a lower load. I would like to highlight some characteristics of the disease. I think that for many years we were waiting for the right test for it, because this is a highly complex disease, a very challenging condition. So it's a chronic granulomatous disease with a very low evolution. The incubation period can take more than 10 years. It's a skin and neurological diseases that affects the skin, the nasal mucosa, and superficial peripheral nerves. I often say that Hansen's disease is actually several diseases combined. So we have loss of sensibility, of pain and heat, spots, and even manifestations with no lesions, which are purely neurological. And the late diagnosis, since this bacteria has a tropism for Schwann cells, the immune response for the infected cells destroys the ability to produce myelin. So patients lose thermal and tactile sensibility, and this late diagnosis is often followed by irreversible consequences. And the several clinical manifestations of Hansen's disease They are associated to the immune response and to genetic characteristics as well. The mycobacterium has been described almost 150 years ago by this Norwegian physician, and it was the first pathogen associated to a human infectious disease. So different from Mycobacterium tuberculosis, it's a mandatory intracellular pathogen that replicates in macrophages and Schwann cells. The duplication time is extremely low, around 14 days, and it duplicates in colder areas of the body, between 27 to 30 degrees Celsius. Another complicating factor is that Mycobacterium leprae has never been cultivated in an exenic medium. So that has limited the offer of antigens for the development of diagnosis tests. The transmission takes place mainly through airways, the upper airways. So if you live with an untreated patient, you are at a greater risk of developing the disease. There are different animals like this armadillo in the United States that are also hosts, but in Brazil, the transmissions happen mainly due to untreated patients. This is the only mycobacteria that infects the Schwann cells, and the consequence of these infection, the immune response ends up destroying these cells and their ability to produce myelin. That's why patients lose sensibility. It's a disease that has a very strong social stigma because it deforms the hands and leads to irreversible physical inabilities due to the progressive neural damage caused in the Schwann cells. We have bone reabsorption. Patients with a late diagnosis can present different levels of loss of physical ability. And Hansen's disease diagnosis is based in clinical signals and symptoms, which requires a lot of expertise from physicians in order to do a differential diagnosis with other skin diseases that might be mistaken for Hansen's disease. So besides the different lesions on the skin, besides the loss of thermal and pain sensibility, we can have the thickening of the nerval stems, and patients might not present a single lesion in their skin and still suffer from Hansen's disease. We have complementary lab tests that are not part of the lab routine in the public health system, like the bacilloscopy, which has a very good specificity, but the sensibility depends a lot on how the test is conducted and on the pathological study, if granulomes were present in all the samples. But it's an invasive test as well that requires the collection of material being conducted by a highly trained professional. Hansen's disease, like I said, it can be many diseases in one. Patients can have just a single lesion, like in this picture, or patients can have their whole body covered in lesions with multiple bacillus. Luckily, we can say that 95% of the population is resistant to M. leprae even after exposure. There is a spontaneous cure and people do not develop the disease. When people develop the Hansen's disease, they can have one of several types. This is a classification for research purposes. So in one extreme, we have patients with an immune response that's very high, without antibodies and very low bacillus. And in the other end of this spectrum, we have patients with response with regulator Th2 cells that produce a lot of antibodies. So the serology can be applied for patients that are in this end of the spectrum. They don't have cellular immunity, but they have humoral immunity. So when we talk about serology, we are talking about patients that have a high bacillar load that are producing antibodies. It was interesting to see in the previous presentation that because for many years we worked with tests to detect the cell immunity, like the IGRA test that is used for tuberculosis. We test several antigens and recombinant proteins, and we had a dream. The Ministry of Health actually ordered this study. We needed a rapid test that would detect some kind of biomarker for cell immunity for patients that are on this portion of the spectrum and detect antibodies simultaneously. This was not possible because all biomarkers associated to the cell immunity that were identified in patients with a low bacillar load, patients that were not treated also had the same biomarkers. So different antigens, different biomarkers, but we could not tell apart a patient that different types of patients from patients that were not being treated. So the paucibacillar patients are treated with up to 6 doses of the therapy, and the multibacillars are treated with multiple doses for 12 months.
So in 2001, we've had the decodification of the genome, Mycobacterium leprae, and then new antigens were identified. There was a work together with Adri, coordinated by Stephen Whitten in the United States, testing different proteins, recombinant proteins. Some antigens were more promising than others, but we still keep on working with the PGL1. This is an antigen that was described over 40 years ago. It's a specific antigen, specific of the wall of M. leprae, and the antigenic part has terminal substances that characterize this antigen. And since it's a sugar, the antibodies produced are mainly IgM, IgG, and IgA, but serological tests are based on the detection of these anti-PGL1 antigens. So this is the best biomarker for serology of Hansen's disease. It detects the vast majority of multibacillary patients, and paucibacillary patients have a negative or weak serology, so we do not have biomarkers for them yet. Several studies evaluated the application of serology to classify pauci and multibacillary patients because their treatments are different. To identify also the contacts with high risk of illness, to monitor the therapy, and to help with the differential diagnosis between Hansen's disease and other diseases. The native PGL1, which is a phenoglycolipid, since we do not have the way to cultivate the bacteria, there are several synthetic or semi-synthetic forms that have been used to make the diagnosis. Sometimes they use bovine albumin, and Dr. Samira Buher conducted her PhD in Holland, and she conducted her PhD with PGL1. She developed a deep stick, but it took 2 hours to read it. So later on, Dr. Burer developed a quick test, an ML flow anti-PGL1 test. So the antibodies reflect the bacillary load. So these are indirect biomarkers of the multibacillary infection. These patients, the multibacillary ones, are the most important in the transmission chain. So at UFG, at the university, we have a platform for production of quick tests, and we have been able to produce these tests for several research groups in a very reasonable quantity, but within specific research projects. So the question is, what would be the application of serology for Hansen's disease at the public healthcare system, SUS? To search patients undetected, which are the patients at more risk of illness. So to find new cases and having a test to do that, it can also help the multibacillary disease diagnosis, decrease the delay or a late diagnosis and the risk of deformities related to the diagnosis. And the serology is also helpful to select contacts with the high risk of illness, especially regarding the multibacillary form, and also possible candidates for chemoprophylaxis after exposure. In a way, it's the offering of a test can empower the healthcare provider. So regarding the strategy of the Ministry of Health, with a zero goal strategy, the disease has been, this Hansen's disease, zero infection, zero disease, and zero stigma, this has been postponed several times. So between 2021, 2025, we aim at the optimized use. We aim for prophylaxis post-exposure. And between 2026 and 2030, we plan to implement new tools, including the diagnosis test. The best one that we have right now is the serology anti-PGL1, and new vaccines have been tested as well. So in this strategy towards zero Hansen's disease, this global strategy, by 2030, we want to increase prevention, detection of cases, detect new cases, increase chemoprophylaxis, detect cases in target populations, and test the use of new vaccines. So to control Hansen's disease and its complications and prevent new comorbidities or deformities, sorry, and detect early cases. So the delay in detection is shown by the high proportion of patients that are diagnosed with some sort of physical disability. So within that proposal of the Ministry of Health and the coordination of surveillance of diseases, we've had a project funded to develop and apply quick tests that are easy to use, that might be incorporated in the healthcare system. The Federal University of Goiás and Dr. Samira Burer signed a contract with BioClin Laboratories, to transfer the technology of production of the ml flow test to detect antibodies. In August, BioClean Laboratories obtained the authorization of the test at Anvisa. So this process is right now at Conitec for the approval. And with that, I would like to thank you for your attention. I'm available for questions. Thank you so much.
Nós é quem agradecemos, né, a sua palestra, doutora. E a gente
We
também...
thank you for your presentation, Dr. Marianne. Thank you so much. And we would like to move on and hand over to Dr. Daniela Soares to talk about the test of HIV and syphilis. Good morning, everyone. I would like to thank the organization of the event for inviting me for this incredible event. It's been an honor to share information in this event. I'm just going to wait a couple of minutes to have my presentation on.
Então, estão dando continuidade, né, à mesa que trata das incorporações tecnológicas no SUS e o que esperar.
So considering the technological incorporations in SUS and what to expect for 2022, I would like to present the results of the duo test for HIV and syphilis that was approved by the Ministry of Health. I work at an institution called Evandro Chagas. It's a science and technology facility located in the state of Pará and linked to the Ministry of Health. We conduct investigations in tropical medicine and environment. The goal of our project was to evaluate the applicability of the rapid tests for a simultaneous diagnosis of HIV and syphilis. We designed the research based on a protocol, on an international protocol of a multi-center clinic-based study. It was a descriptive and analytical and transversal study. We complied with all good practices. The PAHO also evaluated the study. We conducted training of the field and laboratory teams. We also created communication material. So we went to field after the lockdown and we had about 3 months of work on the field. We conducted all training of the teams, a review of the forms to insert everything in the database, and we also created an image bank and dealt with all the issues of managing the project so that we had all the phases mapped. The project wanted to answer 3 questions. What is the performance of rapid tests for syphilis HIV in a real life scenario? Is the simultaneous rapid test would be accepted by SUS users? We've seen in previous panels that the Ministry of Health has different points of access and has a policy of increasing the access of rapid tests. But right now, the tests are presented in individual devices, so the user of our healthcare system can choose if they want to be tested for HIV or syphilis or other diseases. And we also wanted to understand what would be the receptivity, how the healthcare providers would receive this new platform if it were to be incorporated. Because there are also structured policies, online platforms for training, and an external quality evaluation of these professionals that deal with rapid tests in Brazil.
Regarding acceptability, we conducted a study with 419 pregnant women that were being seen in health clinics in the city of Belém for their prenatal appointments. We talked to 56 men that have sex with other men in a different healthcare facility and 77 sex workers in actions that we conducted with the support of the city department of Belém. We knew that the syphilis and HIV prevalence in the city of Belém was extremely high. Among the communication materials that we developed, we have this one that supported our acceptability study because initially it allowed us to differentiate for the volunteers all the different entrances that people had in the healthcare facilities, the moment they went to the lab and the moment they returned to the healthcare service facility to receive the results and the treatment if that was the case. The second process is the process that we have today in the different health clinics in Brazil, which is testing that is conducted during the appointment, but with individual testing devices, one for syphilis and one separate one for HIV. And patients can choose if they will test for both or not. And the process of the research we did, it was a very similar process to what we had before, but with a simultaneous testing where, in this case, patients could not choose. So our target audience, pregnant women, the vast majority were up to 24 years old with an average income of up to 2,000 reais per month. And they share this income with around 5 people in the family. They were non-white, with a high school education. They were heterosexual, usually living with their partners. And what we noticed, because the questionnaire also allowed us to know different behaviors from these people. So the group of pregnant women didn't have much knowledge about the prevention and the transmission of syphilis and HIV. That includes the possibility of vertical transmission. And they have very little knowledge on the prevention strategies that are already available today in Brazil, which is PEP, PrEP, and the self-test. For the second group, the group of men who have sex with other men, the division between young men and adults, young men up to 24 years old and adults up to 48 years old, was equal. Their income was higher than 2,000 reais. The majority was single. They had an upper education, and they did have knowledge on prevention and the transmission of these diseases, except knowledge on vertical transmission. And they were also aware about access to PEP, PrEP, and the self-test. The sex worker group had a profile of young people and adults with an income that was lower than 2,000 reais. They had the lowest education level in comparison to the other groups. They only had elementary school. the majority would declare themselves straight or heterosexuals or bisexuals, and they were aware about the transmission and the prevention of syphilis and HIV, but they had little knowledge on PEP, PrEP, and the self-test. However, overall, all three groups, the group of pregnant women, men who have sex with other men, and sex workers, they said that they accepted the rapid test format. They even preferred it to the lab tested because it's more convenient. Talking about the test itself, the test that was assessed, the possibility of doing a simultaneous test for HIV and syphilis, more than 80% from each group said they would accept this simultaneous test and they wouldn't mind that they weren't able to choose between doing one test or the other. And we asked further questions to learn more about what would make them test more often or make them get tested more often. So the group of pregnant women said that if they didn't need to be cut many times, they would test more often. Or if blood didn't need to be drawn, they would test more often. They would test more for the maximum number of diseases. And if they didn't have to wait more than 30 minutes. More than 40% of pregnant women also said that if the appointments could be scheduled faster, they would also get tested more frequently, and that they would like to be tested at home and without the use of needles, and that represents around 23% of them. The second group, the group of men who have sex with other men, I would like to highlight that they would also test more often if there wasn't the need to use a needle. They also like to get tested for the maximum number of diseases at once. They also would like to wait up to 30 minutes, but they would like to have access to the tests in campaigns that are organized or in different events that are hosted on the street, and if they had the possibility of being tested at home or in their workplaces. For the sex workers group, I would like to highlight that the time they needed to wait was important. They would like to wait up to 30 minutes only. And especially for the group of pregnant women and sex workers, they said the same thing. We arrive at the health clinic too early, we go through the triage, we do the test, and when we have to wait for a long time for the results, that is really tiresome because many of them have to go back to work and there were other issues associated to that. But the sex workers would also get tested more often if we had more testing campaigns available and if they had quicker access to self-tests. We also discussed the usability of the tests. In this case, we assessed the health professionals that actually execute the rapid tests in the healthcare services in the city of Belém. So we talked to 138 health professionals in different points of cares, and that includes maternity wards, emergency rooms, and outpatients clinics, among others. Basically, they received the kit, the box with the kit. The kit that we assessed is called SEG Bioline, or HIV Syphilis Dual from Abbott. Just as a side comment, the project wanted to assess two other products from different manufacturers, Kimbio and Medilabson. But in the moment the research was conducted, these two manufacturers didn't have tests available. and we only had products available from Abbott. And in a number that was a little bit below the number we needed. But going back to the results, the health professionals, they received the kit and they had to handle each part of the kit, the instructions for use, the solution, all the different devices. In this study, we assessed all the products that were provided by the manufacturer, but they're not necessarily the same that are part of the kit. And this change was because this part of the kit has already been standardized by the Ministry of Health. And the health professionals also watched a video with instructions of use provided by the manufacturer. So after this initial contact, they conducted the test in their peers. So one health professional did the test in another health professional, and then they answered the research questionnaire. What was the profile of the health professionals that participated? Around 57% had a technical level of education. They were already conducting tests for over a year, 30% of them. These professionals stated that they were trained in the health care clinic. They were trained by more experienced colleagues, and the vast majority, around 90%, didn't know about the online training platform called Telelab, which is a platform developed by the Ministry of Health, and there you can find training on the use of all the materials that are part of the public health system. And they also said that they didn't know about another strategy from the Ministry of Health, which is the External Quality Assessment, which is a program where health professionals receive a proficiency panel and can conduct a self-assessment. May I continue? Talking about the usability of the dual test, the vast majority thought that the test was easy to understand, the instructions on the inlet, the instructions of use, and the video. It was easy to open the package of the device and to handle the different materials as well as the solution. And it was also easy to read and interpret the results. So from all these parameters, the one that had the lowest evaluation was the use of the pipette, but almost 80% of this group considered that it was easy. And then we also asked the health professionals if they thought that any user from the public health system would stop getting tests if only the dual tests were available. And the majority, 90%, answered no. Patients would not stop getting tested. And then we asked if them, as health professionals, what would they prefer to do? To work with a single test or with simultaneous test devices? And the majority, more than 80%, answered that they preferred to work with a simultaneous testing device. And they reported many reasons for that. Faster time of service, the availability of storage space, and the purchase of these materials would also be easy. Regarding the accuracy of the tests, meaning assessing the specificity, the sensibility, and the positive predictive value and the negative predictive value of the tests, we drew blood with vein puncture. We took this material for the Evandro Chagas Institute to conduct the gold standard tests on the samples. And basically what we did was to do a blind and independent comparison between the teams. And the rapid test, we also collected samples from it in the moment of the appointment, and these results were verified by 2 people in the team. So in terms of accuracy assessment, these are the results I would like to highlight regarding syphilis. Because we know from the literature that the standards for these tests have already been assessed in other countries, and the results that we have available in the literature are also results that are more agreeable to HIV and less for syphilis. But what we see here, thinking about the data that WHO has pre-qualified for this specific test, I just would like to highlight that we assessed a test in a real-world scenario, a test that had already been pre-qualified by WHO for syphilis with a sensibility of 87% and a specificity of 99.5%. This pre-qualification work already ensures the purchase of this material, especially in countries that lack an infrastructure of regulatory work. But we also assessed all the different standards published by the Ministry of Health of Brazil. For syphilis, that means a sensibility of 94.5% and a specificity of 93%. So when we look at the data from the dual test for syphilis in comparison to the gold standard test that we delivered the FDA BS, because it's also a trypanemic test, we saw that the sensibility was 93.95%, much higher than the sensibility that was observed in the WHO assessment, but a little bit lower than what is recommended for individual tests by the Ministry of Health. And that is true for all 3 groups. The accuracy or the global assessment of the test was pretty high, more than 99% for syphilis. I just would like to reinforce that all the parameters assessed for HIV were 100% for all the parameters. And when we assessed the kappa index, we were able to identify an almost perfect ratio between the 3 groups. So this demonstrates that in terms of accuracy, the performance was satisfactory. So, in conclusion, we conducted this investigation on usability, acceptability, and accuracy. Acceptability was really high. The usability that was perceived by health professionals was also pretty high. So from the perspective of users and health professionals, the test would be well accepted. The accuracy level is satisfactory, which would allow us to incorporate and include these tests in a public policy strategy. However, this work needs to be well aligned because we also observed a lack of knowledge on the prevention strategies that are available. So as more tests become available, we also need to inform this population so they can access healthcare services. And they will do that once they get a better understanding of the risks associated to these diseases. At the same time, we need to invest and think about new communication strategies for the telelab platform and for the external quality assessment program, so we can keep all these services happening.
So to answer the question, what to expect from technological incorporations at SUS, we conducted an event on September 17 and debated a lot with all our business partners in the city of Belém, and also through video conference with the technical staff from the Ministry of Health. And I think Alison mentioned yesterday that the Ministry of Health will include simultaneous platforms for the diagnosis of HIV syphilis. The initial purchase will be of about 4 million tests, and the application will happen during a prenatal appointments. We normally start a project trying to answer to 1 or 2 questions, but we conduct the project, answer the questions, and get even more questions throughout the process. So one of the things that we have thought a lot about after our activities on the field is that when we look at the life cycle of a technology for health, from basic research, prototypes to implementation, when we get to the use of the technologies, we have to invest so that the whole previous effort on research is actually used. So at the Evandro Chagas Institute, we will incorporate in our research line the idea of design of services to incorporate these technologies at the public healthcare system using management tools so that we can design better this experience journey for both manufacturers, users, and managers, so that we're able to provide more access and health to our population. With that, I would like to thank you again for having me, congratulate the organization of the event, and I would like to thank the whole team working on this project. We have worked about 12 hours a day during the implementation. I would like to thank all the volunteers, all the participants. Again, thank you. Thank you, Dr. Daniela. It was a very interesting talk. And moving on, I would like to move over to Dr. Pamela Gaspar, who will talk about chlamydia and gonorrhea. Good evening, or good morning, good afternoon. Thank you so much for having me. It's a pleasure to be here and share this panel with such great professionals. It's been very interesting to watch this event with such interesting debates. Are we good to go? Okay. So in order to answer the question about technological incorporations in SUS, I will talk a little bit about chlamydia and gonorrhea. So I would like to highlight that chlamydia and gonorrhea are STIs that, when untreated, can cause severe consequences to the patients, leading to even infertility. So these are diseases that really are considered very important in terms of public health. So that's why we put a lot of effort to incorporate the diagnostic tests in the routine. Before talking about these tests in SUS, I would like to talk a little bit about the background and how we got there. Considering all the technology that we use, it has to be registered at Anvisa, but there has to be an interest to be used in the public healthcare system routine. And then Conitec will evaluate the efficacy, the accuracy, the safety of the technology, and also there will be an economic assessment comparing to other existent technologies in the system. So right at the end of this path, we will have the result, if it's a positive result, to incorporate this technology in the public healthcare system. So what is the scenario for chlamydia? In 2008, the test was incorporated. It was a test by hybrid capture. This has been present since 2008, and it did not include gonorrhea or other molecular biology technologies. So with time and technology advancements, new tests became available on the market. First, including chlamydia and gonorrhea without changing costs, and also used nucleic acid and not only hybrid capture. With that, we are able to improve the sensitivity of the tests, and examples of those are PCR, RT-PCR, and TMA. So with that, the results are presented separately if chlamydia, gonorrhea, and so on. So since 2019, we've had this technology incorporated in SUS, and we requested the change to use the molecular biology technology. This change was accepted by the system, and so we now have this procedure of conducting these tests that use molecular biology of both pathogens. So once we have this protocol following all these process of incorporation, so with that, it was able to include in the protocol, which dictates the use of this technology in SUS, we were able to include how to test and who would be able to use those tests. With that, we've had another question. After 20 years of attempts, we were able to launch the first nationwide antimicrobial susceptibility surveillance for gonorrhea in Brazil. These samples were collected in 2015-2016 in Brazil, and we observed a high resistance to penicillin and tetracycline with a high resistance to ciprofloxacin. But at that time, the national recommendation of treatment for chlamydia and gonorrhea was ciprofloxacin, because we had no enough evidence to include other treatments with Conitec. So from there on, we were able to change to azithromycin because it has an average resistance, and ceftriaxone and cefixime had a high sensitivity. So then we changed the treatment to ceftriaxone and azithromycin. So this shows that it is important to test for gonorrhea due to the issue of gonorrhea. And then we've had the case in London in 2018, which was considered the worst gonorrhea case in the world. And after that, several others were diagnosed. So the world was actually at alert regarding the disease. And so in 2018, we presented the results of these studies and how we incorporated the surveillance in SUS and the challenges that we faced in the World and European Congress of the Appliance of Science. We had the political opportunity window for diagnosis, this policy window that I call, and I call it PrEP. So PrEP was a subject in the world, and so people asked me if we had the traceability of these patients of gonorrhea and chlamydia, and so we showed that we had all this project, but it seemed that that success that we presented was kind of doomed because we were not looking to STIs. Of course, we were looking, but we did not have effective actions. So when we talk about the incorporation of technology, we can talk about that since 2008. A lot of people have been fighting for that. There was a change of the procedure to use molecular biology. There was a guideline recommendation to use these PCDT-IST tests. And so the patient of London, all of that together created a commitment for us to try to incorporate this technology in our routine through a centralized acquisition, procurement, and centralized management together with all entities in Brazil. That's why we decided to implement the test pilots for chlamydia and gonorrhea in SUS. It includes the tracing of asymptomatic people and diagnostics of symptomatic people. Results are not issued right away, but these tests are very important for patients when they come back for a return to see if the treatment was for a current infection, if there's persistence or resistance, to refer treatment for a sexual partner or detect other microorganisms that can generate the same symptoms. What is the strategy of this pilot? To understand the dynamic of implementation of these molecular biology tests and estimate the demand for future procurement, both in municipal, state, and national levels. Up from 2018, when this technology was incorporated, this procedure changed to include all molecular biology technologies. And these guidelines provide this traceability of asymptomatic people as well as symptomatic patients. This pilot implementation has today at least one laboratory in each state. In some states with more inhabitants, like São Paulo, Rio de Janeiro, Rio Grande do Sul, they have more than one laboratory. 100,000 tests, Abbott real-time CT and G were procured. We were already using the capacity already existent for HIV. And that's another challenge for SUS, because for each disease, a new lab has to be installed and has to share the same staff and the same facility. So we're trying to use the existing technology in SUS because the pieces of equipment have the capacity to do so. So the biological samples are urine, vaginal and endocervical swab. And these are examples of the series of actions that we are conducting. A lot of initiatives have been necessary when we talk about the incorporation of a new technology in our routine. So several documents had to be registered. Several meetings were conducted with state coordinators and laboratories. We also collected samples, had the coordination with logistics, provided online training about sampling because this was a new procedure in SUS, and we've been providing support and are almost in daily contact with the network. We have also conducted a webinar to raise awareness of the clinical professionals about the importance of this test. We want to shift the paradigm of why do I need to test if the antibiotic is much more cheaper. But what about resistance? What about super treatments? Or if you do not treat, what has to be treated? So all these issues were approached during this webinar together with the Brazilian Society of STIs. All videos of training sessions and webinars are available online.
So what were the challenges that we faced in including these new technology? Well, the tests that were acquired are not validated for extragenital swabs. And they would be very important because these are areas that are also infected in the body, especially by gonococcus. And the pharynges is an area that develops resistant strain. So it is very important to swab these areas as well. The primary tube for the collection of urine is not part of the kit. The tube that's on the kit is only for storage. And the logistics of sending materials for different locations is quite challenging because we should send the cold materials to the lab from the health department, and that is a huge challenge. There was also the need to create a new local organization, provide training for different professionals, and define the different flows. And every time you need to change a process, that it's always a challenge to do that. The work overload in the laboratory professionals, because that's one more thing that they have to do in their daily routines. How difficult it is to request tests and to see the results, so challenges associated to the information system, and the need to raise awareness among managers, health professionals, and the population to get tested for chlamydia and gonorrhea. So what can we expect from the future? We hope that the results from the pilot project will be satisfactory, and they will reinforce the need for creating this final network, together with the network we have for HIV, hepatitis C, hepatitis B, which is managed by the Ministry of Health and by the Department of STIs, which I belong to, a shared acquisition between all three spheres of government. And maybe besides using genital samples, we can use extragenital samples. What we hope for the future, and these are ongoing strategies, by the way, is that we can use the etiology from male urethral samples So maybe we could, there's another front of this project, which is collecting samples to do molecular biology to detect several pathogens, to understand the etiology of these samples in Brazil. And for those samples that we detect a specific organism, we can assess for resistance, because this is another challenge of a pathogen that is developing antimicrobial resistance. Another ongoing action we have is the creation of the pilot network for the detection of chlamydia, gonorrhea, TB, and MG. So the idea is to determine the prevalence of these 4 pathogens in pregnant women that are doing the prenatal appointments in the public health service, because they can serve as a proxy for the overall population, according to WHO. So with that information, we can try to incorporate the technology associated to these other diseases that are still not part of the public health system. And finally, for future pilot strategies, we can use rapid molecular tests to expand access to this technology, and it has been demonstrated throughout the event. Yesterday, José talked about this, and other colleagues also touched on that point today. We have to have a more etiological approach, so maybe we can assess resistance and provide the best treatment according to that result. Self-sampling is also an important strategy, and telemedicine, because with COVID, it has been demonstrated that this is a necessity for the public health system. That is what I had to share with you. Thank you very much, and I'm available if you have questions. Thank you, Dr. Pamela. I'm sorry, I think his connection is a little bit unstable. I cannot hear him. Now, I would like to invite Dr. José Eduardo Levi to talk about HPV. The floor is yours. Good afternoon, everyone. Can you hear me? Yes, we can hear you now. Good afternoon, and thank you for the invitation. It's a pleasure to be here with you. I'm going to talk about HPV. You can see my presentation, right? Perfect. So my name is José Eduardo Levi. I'm a biologist. I have a PhD in virology, and I work in the University of São Paulo researching HPV. I have been doing that for more than 30 years. And it's a pleasure to talk to you about the possibility of incorporating the HPV test in the public health system in Brazil. These are my disclosures. WHO recently established a target to eliminate cervix cancer. And the target is that by 2030, all signatory countries would have reached the 90-70-90 goal. So 90% of girls under 15 are already vaccinated. 90% of women with lesions and cervix cancer are receiving treatment or have been treated, and 70% of women at the screening age have already done at least 2 screening tests in their lives, one by the age of 35 and the other by the age of 45. These are the commitments we have made for 2030. WHO in 2018 published a list of essential tests, tests that every person should access in their lives to complement the list of essential drugs that is always published. And for the first time, an HPV test was part of this list. More recently, not only WHO have defended the use of screening for cervical cancer using the HPV test, but they also published a guideline about the implementation of this initiative in different screening programs. And a foundation of the use of HPV tests to substitute traditional screening, which is conducted in our country through a cytology test. We can see studies that were produced in the last decade, large randomized populational studies that basically compared one branch did HPV tests, the other branch did cytology, and basically they followed these women for some time and then analyzed the tests that were able to detect the highest number, the larger number of lesions, besides having other secondary targets. This is a very remarkable work by Lancet because it is the combination of the 4 major studies from these countries that has proved that an HPV-based screening promotes a much better percentage, a 60 to 70 greater percentage against cytology. And a follow-up of these women for many years have also shown that it is safe, that this testing interval could be of at least 5 years. This has proven the validity and the advantage of using an HPV test. And the strength of this approach comes from the sensibility. An HPV test has much higher sensibility than the cytology for the detection of lesions and high-degree lesions and cancer. This sensibility for cytology is around 50 to 80% when it comes to cytology. Molecular tests have a sensibility of around 90 to 99%. That would generate a reduction in the number of screening procedures like colposcopies because of lesions or that might or might not be the real lesion that would generate a cervical cancer. It also allows to increase the screening interval, and it brings automation. We don't have a subjective analysis that would depend on the training of the professional, which is quite difficult. And with that, we would be able to reach a high productivity, something that would be very difficult to achieve with cytology. And this high productivity is necessary when we think about the screening of cervical cancer. The clinical specificity is a disadvantage because the vast majority of women who test positive for HPV DNA don't have a lesion. And that makes it more difficult to use screening algorithms and to provide recommendations. So until we solved that problem, that was an issue that has delayed the acceptance of this kind of approach by the different scientific societies and by the regulatory agencies. And one thing that is always mentioned is the cost. We're going to talk more about cost later, if this is a valid point or if it is just something that is said by those who oppose the use of molecular testing in the public system. This HPV test is cost effective for screening HPV in all these countries, and it is part of every country that conducts this type of analysis. Of course, since this was done in Brazil, recently we have published a study that was conducted in the city of Indaiatuba, in the public health system of that city, with costs that were real costs from Brazil. And since we don't have the HPV test in the public health system, we created an estimate of $30, which seemed quite high to me, to be honest. This study clearly demonstrated that the HPV test has a good cost effectiveness. When the ICER is negative, it means that once the test is introduced, you will be able to save resources. And we have 2 approaches here, a purely HPV test approach and a hybrid approach with a cytology for a certain age group and HPV testing for an age group between 30 to 64, which remains with a good cost effectiveness. So it has been proven that in the Brazilian reality, the HPV test will not lead to more cost. It will actually help us save resources. And it's not just about the sensibility and the economic issues and the fact that we save lives, because these women are they're active women, they're working, they have children, they have grandchildren, they are working, and they suffer from a disease that is not only detectable, but it's preventable. It's the only human cancer that has a single cause and it can be early detected. So for that reason, many countries in the world already started replacing the cytology screening for HPV test screening. We see countries that already have national or subnational level programs. So these countries do not use cytology. Australia, Turkey, Holland, the UK, and some areas of Spain and Portugal, and in the US, Mexico, some countries in Central America, Argentina, and other countries that have started pilot studies a long time ago, like Paraguay, Peru, Ecuador, Colombia, El Salvador. So all countries with a high occurrence of cervical cancer are either screening these cases with an HPV test, or they have ongoing pilot projects to do that. India is another example. It's another country with a lot of cases of cervical cancer. Let's remember that HPV is a DNA virus. And if we follow the central dogma of molecular biology, DNA, RNA, and protein, we can use the virus DNA, but we can also use the RNA or even viral proteins or cell proteins that are produced when oncogenic HPVs are affecting the cells. And for that, there are many possibilities of tests. That's tests that target the DNA, tests that amplify the RNA, and tests that detect protein like E6, E7, or cell proteins that marks the oncogenic proteins from HPV. The DNA-based tests have the highest clinical sensibility, which gives us the biggest negative predictive factor. Protein-based tests, they have a better clinical specificity, so a better positive predictive value. So we have to work with these two pieces of information, because every time we are talking about screening, what we want is to have the best negative predictive value. When I say that a woman doesn't have cervical cancer, they don't have it and they can come back in 5 years. When I say that that woman has cervical cancer, that might be true or not, but we need more tests to prove it. So for that purpose, we create a global market, meaning all women that are at that screening age group. So that's why we have so many tests. We have 254 HPV DNA tests available. Unfortunately, the vast majority of these tests, more than 90%, do not follow the quality requirements for these HPV tests, and 81% do not have any type of study with a peer review analysis. So the message here is HPV tests, yes, they should be used, but not any test. We need validation. We need to know about the clinical experience behind the use. So when I say that cytology, we shouldn't use it, it's useless, that's not true. It should be reassessed. Some algorithms that are already being used for countries that have HPV tests for screening. In the US, they do the test. If it's negative, women come back in 5 years. If it's positive for some type of the high-risk HPV, that sample goes through a cytology, so a test with a more sensibility and then a test with a higher specificity. If the cytology comes back normal, that person comes back in a shorter period of time. And if the 16, 18 is positive, we go directly for colposcopy because of the high positive predictive value. So we don't do a cytology in that case. Holland is a little bit more conservative. They combine all this in a single result that is then sent to cytology, that is a cytology that is repeated after 6 months when positive.
So the introduction of the HPV test does not eliminate cytology, but it makes cytology a better test. So this is a job being conducted in the Public Healthcare Center in São Paulo, in one of the largest centers for SUS, where the use of cytology without and with prior knowledge of HPV status. So we can see that the detection of high-level lesions was much higher with prior knowledge of HPV than without. One other thing that I would like to highlight is why to make this differentiation of the genotypes, because they are very different. So for example, HPV 16 has a accumulated risk in 16 years. It's a woman with positive HPV 16 has a much higher risk, a 75% risk. These are also women that have high risk as well, HPV 5 and 6, but present less risk a long time. The Indaiatuba study conducted in Indaiatuba used colposcopy with HPV 16 or 18 positive, and this is already implemented in the public health system. So this proves that we want to use this type of test. It's desirable. In our experience, in a study conducted with 16,000 women, the frequency of HPV genotypes are half of the frequency. When we look at the cytology rate, we can see the oncogenicity of these HPV tests. And with this transversal study, these women that had these types of HPV did not have this cytology rate. So there's a less need of screening. And to close, after the learnings with COVID-19, we have a high capacity installed in the country. And so with the elimination of COVID-19, we will have use or no use for all these machines. And so the biggest demand that we have in the public healthcare system in Brazil to use molecular biology equipment is to screen cervical cancer. This is a high demand, the only high demand that I can see today in the public health system. We could also introduce improvements that we learned from COVID. For example, the tests without the need of extraction, since swabs, cervical vaginal swabs, are similar to oropharyngeal swabs that we use for COVID. So with that, the HPV-based screening is desirable, is cost-effective, it improves the quality of life of these women and anticipates a preventive treatment, it cures, and it's economic for the public health system. The fact that it will not be implemented in 2022, but chlamydia and gonorrhea, yes. I congratulate Pamela on doing that, but that is not backed by WHO or other health entities. It's not because of economic issues. We have to find out why is there such a resistance for an important change for our country, which is a country with high occurrence of cervical cancer, which is a shame for our country. Thank you so much for listening to me.
Muito obrigado, Dr. José Eduardo.
Thank you so much, Dr. José Levi. It was a very interesting presentation. We are almost out of time. So if we have any questions that have been sent for our speakers, they will be available on our website and will be answered later on. So right now, I would like to thank all the speakers for their presentations. And I would like to highlight that each talk had similarities with others. When we talked about stability of the sample, the time of transport of the sample to the laboratory, this is a very important aspect that was mentioned during the TB presentation. When we talked about Hansen's disease, it's very interesting that it was a test developed in our country. And I would also highlight that that should be more published, broadcast about the accuracy of the test. Another important point is the perspective of the user. We pay attention to the technical aspects, but the acceptance of the patient and the staff and everything regarding a change of an equipment or device is very important when the test is closer to the patient. Dr. Pamela also talked about the difficulty of working on that, on the access and acceptance. And just like Dr. José Levy mentioned, there is another dimension regarding prevention, which relates to these tests. So I think all the presentations kind of complemented each other. And it was an honor to be a moderator for this event. I would like to thank everyone who sent questions, but due to a lack of time, we won't be able to answer them live. They will be available on the CBDL website. I would like to thank Dr. Carlos Gouveia for inviting us and for having me as a moderator of this panel. Thank you so much, and let's move on with our agenda. Thank you. Thank you, everyone. Thank you, Dr. Alvaro, Pamela, Danielle, Marianne, and Erica. I think this was a fantastic panel, and this single panel would constitute one event. These are issues extremely important for new actions. So now I would like to invite Robin Moran, who will coordinate and moderate the next panel. Martha, Elliot, Pamela, Danielle, and this panel is going to be about the future, considering what we've already discussed.
Robin. Yeah. Elliot and Martha, are you also in the...
I am on.
Yes, that's great. Martha, are you there?
Yes, I'm on.
That's great. Let's see if Robin comes back. I cannot see from here. Let's see. Só segundo.
Yeah, Robin just sent me a message. She needs a minute.
Okay. Okay. But anyway, I think we have had fantastic discussion. Elliot, if you want to start up with your comments from what you have seen so far, and actually touching bases also on what Robin just sent us as key points for today, so just to gain time.
Sure. I just jotted down a few notes of some high points I thought are worth considering. First of all, how important it is to keep up with with variants, especially in the COVID world, but also for any infectious disease. If there are variants, then we need to know the impact on diagnostics. So we hear a lot in the media about concern about whether a vaccine is going to be, the effectiveness of a vaccine is going to be affected by the mutation, but you hear nothing about whether the mutation is going to affect the ability to detect the virus. So infected people may go undetected. I think, as I mentioned yesterday, there were 26 FDA authorized tests, which had elements of them that did not detect the virus. So I want to advocate for that. I also want to advocate for risk-based assessments, especially when it comes to acceptable performance, because it's counterproductive, I think, to expect near perfect performance if that's actually not needed. And so there needs to be some thought that goes into what is considered acceptable sensitivity and specificity. Just a couple more things. I think we also need to take into account manufacturers' ability to manufacture the test. And so it's not running out, the tests will be available when they're actually needed. And also the cost, because sometimes the cost can be exorbitant and not realistic for people to purchase because of that. And also one last thing, I just wanted to advocate also for studies that will demonstrate the utility of antibody tests. What does an antibody test result actually mean? And not have people use those tests inappropriately to determine if they need to be vaccinated or need to quarantine and so on and so forth. So I'm sorry, I'll stop there and let others join in the conversation.
Oh, hi. So it's Robin. So can everyone hear me?
Yes, yes. Welcome, Robin. Please.
Sorry, Carlos.
Take the lead.
I had the wrong link, but anyway, thank you.
You're welcome. We just started, so yes. I asked Elliot just to give a little bit of summary of the key points that we have discussed and his view on the future. But if you want to take the lead, please go ahead.
Okay, thank you. Well, it's really great to be here, and we've heard some fantastic talks over the last few days. And I guess one thing I think that has been a common theme is that there is a need that business as usual can never be what it was. Getting a product that makes a difference to many lives. We cannot do it the way we did in the past. It's too slow. The pandemic has taught us that. So, and I think when we listened to Rosanna's speech yesterday, she was really pushing the fact that we can't have parallel processes and they must can't have sequential processes. They must be in parallel. So how are we going to make this all happen? And so I wanted today to ask the panel, and we have a fantastic panel with us today, just what they would be doing if we were asked to write a template or a blueprint for how to introduce IVDs into the market and be effective using the lessons we've learned from COVID. So I think it's actually really important. It's not just for COVID self-tests, it's also for HPV, for chlamydia, gono. But at the moment, I have a real concern. So since my time at WHO, I've been working mainly on EU regulations. And many of you will be aware that the EU is the regulations are changing. Now, the bar of quality has highly increased. Sorry, I just lost my earpiece. And there's actually a great risk that many products will no longer be available on the market. I know of many big manufacturers who are reducing the number of products they are bringing to market. So we are going to be faced with supply shortages, without doubt. So this scenario of having some sort of template or blueprint on how we should do business now, the new business as usual, is really vital. And I guess the first thing that, one of the things that I think FIND has done an amazing job in, and others too, has been teaching politicians, teaching everyday people just what the diagnostic use case is. And I think there was a poor understanding. We saw at the beginning of the pandemic that tests were just, any test was used in any way. And we realized that not all tests can fill all purposes. And so, Marta, do you want to talk a little bit to us about how important it is to understand the diagnostic use case when you're thinking of introducing a test?
Yeah, absolutely. And I think maybe we can put an example, as you were referring to, with the pandemic, right? Separating what's technically possible versus what the use case for that technology is very important. Early on in the pandemic, the first tests obviously that came to market were molecular, and they had a clear use case for diagnosis. But then very soon thereafter, we had antibody tests in the market, right? So tests that were able to look at the immune response. And then manufacturers jumped on making these tests, and countries jumped into making use of these tests, right? And we were using serologic tests that were looking at the immune response for diagnosis. And it was made very clear that that was not the best use case, right? So antibody tests are not detecting active infection early on, but rather they become positives over time. So not the best use case for those tests. So understanding what each test is useful for is critical, both to implement it, but also to design the studies, right? When we think about regulatory and others, to design the studies that allow us to prove that the performance of that test is adequate for that clinical use. Then over time, we realized we phased out antibody tests as a diagnostic test, and we placed them where they need to be, which is in seroprevalence studies and for others, and obviously in the context of vaccines. And then the antigen test came, which proved to have a better use case. So I think it's a good example of how it is very important that we define what each test is going to be used for. And even within this example of the antigen test for COVID, then we can talk about, are we talking about contact tracing? Are we talking about diagnosis of a symptomatic individual, or are we talking about a screening populations of asymptomatic individuals? And each one of those use cases will require different studies. It will also require different designs from the product in terms of usability, but in terms of performance. So it's a very different regulatory pathway initially, first different development pathway, second different regulatory pathway, and third different implementation and policy development for each one of those. So we need to be very clear upfront on what each use case for a given test will look like.
Thank you. I totally agree with you. Daniela, you've had experience working in the ministries of health. I'm just wondering if you can give me any thoughts on how useful target product profiles might be, not only for developers, but maybe also for the ministries of health. I'm not sure how familiar you are with using them, but we've seen WHO have produced a number for COVID, and MHRA, the UK regulator, did too. Have you any thoughts on this matter?
Ele tinha ligado esse.
I haven't been working specifically with COVID, but certainly the lessons learned, they contribute a lot for other diseases. Within the context that the three of you gave us, and along with our discussions, it is important to highlight that we should approach not only the pre-analytical phase or the analytical phase or just the post-analytical phase, which includes the insertion of these materials in the market, but we cannot miss the diagnosis opportunity. what we could call the pre-analytical stage. Many times patients, they don't know that they need to have, they cannot eat before the test, or they don't know that they should provide do a certain hygiene process before doing the collection. So what happens? They arrive at the health clinic, they receive that information, and they go back home, and we're not certain that they will come back. So we miss an opportunity with that. Thinking about the post-analytical stage, in my understanding, when we include new technologies in the public health system or in the different global health systems, we also should consider this stage as a post-analytical stage. What can citizens understand from the result from the test? And having a message like this: listen, you should see your doctor right away, or stay home until you can schedule an appointment with your doctor. Stay self-isolated. Basically having these messages that users and citizens can be a part of, so they can be included in the process. So yes, I do believe that we also need to study this journey, not only the patient's journey, but the journey that different health managers go through in this process of acquiring and distributing these products. I think this is what I had to say. Pamela, you also work in the ministry. Would you like to add any comments? Hi. Certainly, I agree with what you said, Daniela. We still have a lot to learn. We have learned a lot from COVID, and I'm sure we will be able to improve the work we do from now on. But regarding this movement that WHO does, that is becoming stronger with the TPPs, or the target product profiles, it is very interesting because people don't know exactly what is the best sensibility or the best specificity, or what is expected from the collection time, how long after they should come back, what is the necessary infrastructure. So once experts gather and define that together, that can help us guide the industry and researchers that invest on researchers that focus on public health needs. And with that, we can have a much more favorable result that leads to a quality access to the whole of the population, which is something that has been reinforced many times during the event.
Thank you very much. Now, Rosanna also said yesterday that it was really important when we're gathering evidence and for policy development that we take account of the breadth of stakeholders that are available to make timely policy development. And she included groups like civil society, the departments of education, trade and finance. And Segundo, I wonder if you would like to give me your thoughts on how important this is, that we consider that that it's not just about talking to medical scientists, which many of us in the room probably are, but expanding when we're thinking of policy development, having an expanded stakeholder group. Segundo, would you like to add any thoughts to this?
Sure, Robin, thank you. Sí, en realidad hay varias cosas acá y me gustaría un poco dibujar.
I could say a lot about this. And first, I would like to give you a broader perspective, because during the COVID pandemic, we were able to see some strengths, some specificity, but especially in terms of diagnosis, we must remember that we had gone through other pandemics before that were not solved just based on diagnosis because of real struggles. We have Hansen's disease, we saw tuberculosis. These are important problems. regarding the development of guidelines. HIV is an epidemic that has been around for 40 years. So if we can develop different guidelines in order to develop these self-tests. We're starting this implementation, but it's not something that is fully implemented in all countries. In the countries where this process has already started, there has been some resistance that we need to fight against, and this is what we need to work on the coming years. So COVID highlighted some weaknesses that should be considered. In this setting, we face a constant change, even though the FDA is a global reference for the approval of in vitro diagnosis products. There's a huge delay associated to other diagnosis technologies. And we do have a complicated scenario for the next months. And probably the same thing is happening in Brazil, Peru, and the European Union. They're changing their regulations. In some situations, we have more harmony, complicated situations. In that sense, inside academia, inside the communities, there is a need to have more transparency in the guidelines with the participation from the authorities from the Ministry of Health, from academia as well, to incorporate not more tests and to spread the technology, because it's not just a matter of having the test. It is important for the population and for health professionals to know that tests are available. And what can users do? What they should do once they get the result.
Thank you. That's really great input. Now, Carlos, I'm going to ask you a question. You know, as tests are introduced, of course, we need a lot of evidence quickly on how to do that. And we have a lot of new technologies that can help accelerate access to that intelligence, be it the results of usability studies, be it the results of surveys of relevant patient groups or whatever. Would you like to tell us a little bit about how you think we can maximize these new technologies for intelligence gathering, and some of your thoughts on how they may be used to actually accelerate this development cycle, or at least the cycle from introduction to effective rollout of a program?
Excelente pergunta, Robin.
That is an excellent question, Robin. And what we see inside the world of diagnosis is actually a need to include a number of different stakeholders that are working together to improve access to therapy, something that can only be done after the diagnosis. And here I'm talking about the right diagnosis done at the right time for the right person by the right people. That is only possible through collaboration. The pandemic has shown that medical societies, the industry, the civil society, together, they can create this information. The example from COVID was the fact that in Brazil, that thanks to the support from the Clinical Pathology Society and others, we created a group that included 13 private and public labs that conducted this huge evaluation on all the new tests, new technologies, tests that were unknown, and many times tests from unknown manufacturers. So this extra help that came from the civil society was essential. It was essential in supporting Anvisa in their decision to create an emergency approval, so that they were able to provide information for our health surveillance agency, including information of post-market surveillance for different actions that were needed. That's the first thing. The second thing, we have performance data for buyers, public and private. These data were good for us to determine what that product was good for. And that also served as additional support to manufacturers and importers that could actually improve their own production, bringing a better lot or a better batch right away. Of course, that worked in a coordinated way so we could really show the value of diagnosis for the whole of the population. We have never talked so much about the importance and the value of diagnosis as we do right now. Here in Brazil, you can stop at a bus station and ask, what is a PCR test? They might not give you all the technical details, but they know why you should use a PCR test and how it's done. This was unimaginable some years ago. So what we see is that it is essential to have a collaborative effort. The project that is being led by FIND is amazing, but it is only possible because we have the help and the support of different stakeholders. What we are doing at ActAid for vaccines, for drugs, and for diagnosis, it's also amazing. This is a group of stakeholders from different areas, from different regions with different styles, and they're all working together to improve access. And let's remember that in the future, what will be valid for COVID could be applied for other diseases. And we're talking about this concept of testing and treating. Testing, so we can use the most effective drug that has a scientific evidence and we know that will work. So we are going through a major revolution. The life cycle of diagnosis that usually lasts 3 to 4 years, and it's highly dependent on the collaborative effort. And I mean research, development, innovation, regulation, access, and monitoring of the market. This cycle usually lasts 3 to 4 years. Now, with information technology, with 4.0 health, and with the collaboration of different stakeholders, we can bring innovative technology to the market much faster without forgetting of removing those technologies that are obsolete now, because we do not have an unlimited amount of resources, but we do have room to improve this idea of providing better health to the whole of the population. So I think that overall, Robin, this is it. It's a great advancement, but that was only possible because of the collaboration of all.
Absolutely. And I don't know if I'm just going to open the floor here. If anyone, I'm going to ask a question that you may not have thought of, but this is something that I've found definitely a problem with the pandemic. And that is when all the resources in government are so stretched. One thing we've been finding is you may make a little progress in progressing a policy or the development of a policy or an agreement on regulation. And then you find that because during the pandemic, everyone's doing so many jobs, you're talking to a different person every day in government, and the information doesn't necessarily get handed on. And sometimes some great progress that has been made stops because there's no access to anyone in the government. Now, this is a real case scenario, because the other day I was invited to a meeting by a government to help consider by a regulator actually, how to help bring in self-testing for COVID. And they said they'd tried to contact their Ministry of Health. All the usual people they contacted weren't there anymore, were in different roles. And so no one who was there knew anything about it. How do you think we can advocate to keep this? Everyone is aware of the importance of IVDs, diagnostics at the moment, but how can we keep this, the importance of our trade in the minds of public servants who are already busy? How do you think we can get this continuum? Because obviously we can do things upstream with to incentivize manufacturers. We can get donors to help with that. We can even get stakeholder groups, the civil society engaged. But sometimes government can unwittingly be the block. Has anyone got any thoughts on this? Because I do know this is a major problem in a few jurisdictions at the moment.
Yeah. If I may reply to your question, we are running out of time, so I'll try to summarize. But the key points here, I think, is really to engage all different stakeholders together in the way that we are doing right now here. So this event is going to bring many results. Not only the presentations that you have seen, but every moderator is going to be invited to write or an article or a summary that we can use. Every presentation, roundtable discussion is going to be available on the internet. It's going to generate byproducts. This is a kind of, let's say, steps that we make and are going to become public. So they can be valid and use it anywhere. Brazil, Peru, Colombia, Guatemala, in anywhere. So these are very, very good proofs of what we can accomplish together from a work like Evandro Chagas that Daniela showed, a work that Ludi Levy showed with HPV, and so many excellent examples. This is something that governments do know, but they don't pay attention. But we are going to go there and knock at their doors and show, look, this is what we, citizens of a country, have accomplished. It's a fantastic material, let's use. The same applies for regulations, for regulators, for different entities. So it's to show what the world is producing. It's a fantastic work, and we are all proud to be a collective part in this fantastic job that has been done. So in a summary, I believe so. And I don't know if anyone wants to also add any remark, please feel free. And then I ask to go for the closing part.
So we're all part of an education campaign. And I think we must we're all advocates, and we must remember we all have a voice in this, I guess, is what you're saying, Carlos, and to keep our voice loud and clear.
Yeah, we all are stakeholders at the end.
Só gostaria de adicionar também à fala de todos, é que a gente que trabalha.
I would also like to add that we that work in diagnosis, that advocate for diagnosis, the word is we have to be tireless. All discussions, every moment that we have the opportunity to reinforce the importance of diagnosis, we have to tell how important it is, because right now during the COVID pandemic, the world is talking about vaccines, but we have to keep talking about the importance of diagnostic tests. So people would say, oh, here she comes talking about diagnostics again, but really, this is what we do. This is the job that all of us professionals are doing, and we all believe in that, and we have to reinforce the issue of diagnostics to promote access. And just like Carlos mentioned, to test and treat, and not only treat.
Elliot, would you like some, and Daniela, two quick final words from the two of you?
Então, eu achei muito interessante as suas considerações.
Yes, I found your considerations, your remarks very interesting. And I'm thinking about your provocation and just, thinking and talking at the same time. This may not be a very mature thought, but we have to use this force generated by different organizations so that we might be able to maybe structure some governance guidelines that we could propose to the authorities of a country, for example, because then we would have a governance guidelines, some standards that whether governments and managers are changing, the intention is not changed. The policies for public health are not changed. So I really am sharing an idea that might be, mature to see if it really works, and it might become a proposal. But I really do believe that since we have agents here that are creating deadlines, protocols, and other documents, maybe this exercise, this quote-unquote homework, could be done by us. Thank you so much.
Thank you. Great. Elliot?
One more thought from me, and that is these workshops are unique. And that is at once incredibly important and incredibly productive. And at the same time, it's a bit troubling because we need more of these. We need people to bring people together, as Carlos and Rosanna and others have done, to workshops like this, to move the importance of diagnostics forward. So I would only hope that this should serve as this will serve as a model, or I think it has, but I'd like to see more of them as a model for moving ahead and advocating for diagnostics. So thanks very much for doing this.
And Marta, I realized I haven't given you a last word.
No worries at all. I mean, just to comment that I think, as you said, this pandemic has created a momentum that we need to keep up. So not to reiterate on what everybody's doing, I would say there is some hope from the government and the politics side. Both from the G7 with the UK presidency, there is a huge momentum with the 100 Days mission, right there. This effort to identify what can we do better for the next pandemic. And also you mentioned the ACT Accelerator, right? The Access to COVID Tools Accelerator. There is now a call to continue that work throughout the next years to prepare for the next. Now, this is still very focused on pandemics or on outbreak pathogens, I should call them. And I think part of the effort that we need to make is to bring that same attention to the need for diagnostics to all of the other diseases that are endemic to our regions and that are very much prevalent. But just like everybody else, I'm optimistic that we can use this momentum if we just keep working together.
Thank you. Okay, thank you very much, one and all. And Carlos, sorry we went over time, but I think it's been a very interesting discussion. Thank you.
Robin, I really appreciate your effort to be here with us virtually, but it was fantastic as to all of you. I think we had great momentum. We are creating a great momentum, as Marta said, after so many different talks and sharing experiences. So thanks a lot. And now I will turn to our last part of the event, calling back Rosanna to say some final remarks and also show a little bit of the options for accelerating access to diagnostic. Rosanna, it's up to you. The floor is yours. Thank you.
Thank you very much, Carlos. And I'd like to take this opportunity to continue the conversation about this unique opportunity to advocate for diagnostics. I think I want to give two examples. One is that Dave Persing from Cepheid, whom many of you may know, he said to me that it's really the first time he has heard in the public that they know the difference between CPR and PCR. And that's a great achievement in terms of, you know, what the pandemic has brought in terms of the profile of diagnostics. And then the other one is when I was talking to Jeremy Farah, who was supporting our work on accelerating access. I said, oh, you know, it's going to be so difficult because, you know, diagnostics is underfunded, undervalued, and it's like the neglected stepchild that no one wants to pay any attention to. And he said, no, don't say that. Say that diagnostics is like the Cinderella of global health. And so now we are at the moment when Cinderella has been invited to the ball. So we really need to make the best of this opportunity. So with that, I'd like to get down to the business of looking at options for acceleration. So I just like to share my slides and show you what progress we've made in terms of at the beginning when we were talking with the different regions about options for accelerating access. we were only talking about, having expedited regulatory review mechanisms, such as the EUA or EUL. We're talking about regulatory reliance, convergence, harmonization, and building on existing initiatives, either in medicine or vaccines or small groups already clustered in terms of their ability to review dossiers. But there is also, within the policy consultations, the need for health technology assessment to be more commonly used in a number of countries, so that we have a means for policymakers to look at what should be done when it's a changing world in terms of the use of diagnostics in non-healthcare settings. And also for vaccine pre-screening, as you heard today, for the dengue vaccine rollout. And then I also thought that maybe we could have these forums more often, just to give regulators and policymakers updates on new technologies, so that they're not just hit with a dossier to decide what to do, but they are not very familiar with the technology to know what its advantages are and what its limitations are. And then, we propose that maybe the groups could come up with other options. And we also show that the WHO has now published a chart on how countries, the NRAs, the national regulatory authorities, could start looking at reliance and starting with just independent decisions to leveraging the work of others or work sharing, and then having a bridge pathways using reliance, and then have a fully fledged reliance mechanism, or coming up to unilateral or mutual recognition. So this was how months ago we started to talk with the different focal points in different regions about these options. Now, what happened in Cameroon was that after 2 days of looking at all these issues, they came up with 12 points for moving forward, and it remains for them to make priorities on which points to make forward. But I'd just like to, for the purpose of this discussion, describe them in groups rather than just 12 points. I think for me, the number 12, saving lives, should be the first priority. That is really important, because after all, that's why we want to have increased access. That's why we want to have accelerated access. The most urgent is to save lives, but of course, it's also to increase health service delivery for people who are not having access at the moment. But that is one thing that they wanted to keep as a very important guiding principle on how to move forward. And then the second is number 2 and number 9, which is that in spite of the fact we want to increase access, we want to accelerate access, there should be no compromise on data and evidence, and no compromise on quality, which I totally agree with. But I think the no compromise on data and evidence in a pandemic, it could be interpreted as more flexible accumulation of data and evidence, just like we are doing with the vaccines at the moment. And then number 7 and number 8 is sharing. Sharing is so important. Sharing of results, sharing of protocols, sharing of best practice. And this is within the African region. And then finally, all the other parts are related to the status of regulatory reviews on the African continent. And so everybody agreed that there should be an Africa regulatory authority or authorities, but with a regional approach, taking into account cultural differences, language differences between different subregions of Africa. And they agree that a regulatory framework for in vitro diagnostics must be developed and not have it just always hidden inside medical devices, which for non-IVD type medical devices, the regulatory framework could be different. And so this having an IVD regulatory framework would allow us to make progress a lot easier and with a more clear vision. And then the regulators, they feel they need to be more flexible to take into account the opinion of policymakers as to the risks and benefits. And they also ask for more capacity building for regulators to know all these advances that have been happening and the changing environment, health environment, as you discussed at this meeting, the new technology, but also a new health environment. How do we keep changing and have a culture of continuous learning? Now, the only part that I haven't touched on is the drugstore offer competition. Now, this is something to explore. And I think in your region, you've done a great job of pharmacies working together with the Ministries of Health, with everybody else, to offer services. Whereas in Africa, what they saw was that drugstores were just trying to make money by offering medicines for COVID during the pandemic and making a lot of money, but with no responsibility, no accountability for what they sell and why they were selling these packages of medicines, especially antibiotics for families and not only for individuals. So I think that's something to be resolved in their region. So I'm pleased to show you that actually the actual regional consultation in Africa that happened last week came up with much richer options for moving forward than we originally anticipated. And so now within this region, from what I've heard the last 2 days, there are, you have different options and different priorities, and you already have quite a lot of really important institutions that could help with this process. The USAID representative talked about the MDRC, the Americans National Standards Institute, NC, and there's Conitech, there's all kinds of societies, institutions that already have infrastructure that could help with this process. And so we need all of us now just to be champions and to work with these organizations that are set up and not to duplicate what others have been doing, but also just work together to make the process more efficient. And we're all trying to champion this, but let's do it in a collective way. And I really thank all of you for all the really good and important presentations on the status of what it is like for in vitro diagnostics on this continent. And thank you to Carlos for organizing this amazing conference. Thank you. Over to you,
Excelente. Obrigado, Rosana. Pra gente...
Thank you, Rosanna. And I can speak on behalf of everyone here. It's always a pleasure to work with you throughout these 11, 12 years, I think. I have learned constantly, and I believe we have also developed a friendship. For me, this is very important, but for all of us Brazilians, we recognize the great effort that you have made and the attention that you dedicate to our region. Without a doubt, this is a seed that was planted many years ago and that today is already generating visible results in improving our regulatory system and improving our access. This international workshop started after a suggestion made by Rosanna Peeling in an event called ACDX, Advanced Course on Diagnosis. And every year we host one edition. And this is the result of a global effort to promote access to diagnosis and to the best treatment available. And we learn a lot, especially through the collaboration of so many people that are able to truly make a difference. So now I would like to conclude and thank everyone who have been with us here face to face, helping us. I'd like to thank the technical team. And I would like to thank all of you who have invested precious time from your day. This has been a great effort and we all need to participate on it. It's very easy to wait something that is ready and developed by the government, but that's not the case. We have the responsibility and we have to take that role and leave a legacy for the future generations through this joint effort. So this is what I had to say. This is the end of our workshop and our seminar. Thank you very much. I wish you all a great day and be certain we will have a lot of work to do in